Good morning, everyone, respected dignitaries, esteemed faculty, and dear participants. It gives me immense pleasure to welcome you all to day 2 of AV Fistula workshop in CME organized by the Department of Burns and Plastics, Aiims Bhubaneswar. After an engaging and insightful first day, we gather again today with renewed enthusiasm to learn, to refine, and to advance our understanding of AV fistula surgery, a cornerstone into the care of patients requiring long-term vascular access. Let us begin today's academic journey. I invite Dr. Parag Sahasrabudhe sir to deliver his talk on hemodynamics and complications of AV fistula surgeries along with an informative video.
Everyone. So today 2 important talks, one about the hemodynamics of end-to-side and side-to-side anastomosis, and what are the different complications that one can face during AV fistula surgery and how to manage them. In between the 2 talks, I will show a video. Yesterday we saw almost all types of fistula surgeries. Only thing we could not demonstrate was secondary transposition of the basilic vein. If the fistula is already done, then how do you secondary transpose? So that edited video I have, which I will show. So coming to hemodynamics, can you hear the voice? I don't know. Okay, fine. So see, the normal flowing river has a very mellow down sound, and this is because the flow of the water is laminar flow here. Okay. Now what happens when there is an diversion or obstruction? When there is diversion or obstruction, what you get is turbulence. Okay. So now this is exactly what happens in a AV fistula surgery, because we are going to suddenly cause diversion in the main arterial flow, and it is going to produce turbulence there. Now whether it is an end-to-side anastomosis or whether it is a side-to-side anastomosis, we are not sure, but turbulence is definitely going to be there, and turbulence will be maximum at the anastomotic side and will reduce as it goes towards the venous side. So our aim is to have a mature fistula at the end of 6 weeks. Okay, the minimum flow rate, as we said, was about 350 to 500 ml per minute, and the minimum vein diameter that we require is about 6 mm. If you see normal cephalic vein, the normal cephalic vein approximately has a flow rate of about 28 plus or minus 14 ml per minute. So let's say about 40 ml per minute. Okay. And in a successful radiocephalic fistula, the flow rate is anywhere between 600 to 1000 ml per minute. So you can see more than 10 times increase in the flow rates in the cephalic vein after you join the vein with the artery. So when there is a sudden increase in the blood flow inside the vein has to adapt, basically by mainly outward dilatation of the vein, which leads to wall thickening and the intimal thickening. So let us see how the hemodynamic changes affect the adventitia media and the intima. So this is a normal, can I have a pointer? No pointer, okay. So yeah, okay. So I can play from here. Okay, fine. So you have, this is adventitia media and intima, and this is patency at 6 weeks. When there is a maturation of the fistula, as you can see here, the media hypertrophies, the intima remains the same, and so as the adventitia. Now failure to mature will lead to this. What has hypertrophied? It is the intima that has hypertrophied, and media has remained the same. So when there is intimal hyperplasia, that leads to failure of maturation in an AV fistula. So when the laminar flow is disrupted because of diversion, you get turbulence, you get vibration, and you get reactionary endothelial cell activity. Now endothelial cells will do 2 things in reaction to this turbulence. One, either they grow in size, they grow in numbers, and the worst thing is they grow within the lumen. So this is how the endothelial hyperplasia eventually, if you see, this endothelial hyperplasia will lead to obstruction here, and the fistula will fail. So this vascular remolding of the vein is basically triggered by 2 types of stress factors. One is shear stress and the second is hoop stress. Now shear stress is basically friction between the blood vessel and the vein wall, which is inversely proportional to vein diameter. So obviously as the vein diameter increases, the shear stress will go down. When there is sudden increase in the flow in the vein, there is release of nitric acid and prostaglandins by the endothelial cells, which leads to venous dilatation, and that is basically to inhibit platelet aggregation and immediate thrombosis. So that's a natural phenomenon. The second is a hoop stress, which is the immediate hemodynamic changes after creation of an AV fistula. So we are joining high pressure to low pressure system, so sudden increase in diameter of the vein, sudden increase in venous pressure. Now this increase in venous pressure will reduce as the vessel wall thickness increases. So if the vessel wall thickness doesn't improve, the venous pressure will remain high. And how do you measure shear wall stress? It's the Reynolds number. So it's basically inertial force divided by the viscous force. And if the Reynolds number is less than 2000, then the flow is laminar. And if the Reynolds number is more than 4000, it's an turbulent flow. So you can actually measure Reynolds number and try and identify whether the flow has become turbulent or from turbulent to laminar. So our whole purpose of maturation, when a fistula matures, initial turbulence which is caused by the anastomosis eventually gets converted to a laminar flow, and that is how the fistula matures. So our goal is to achieve a laminar flow across AV fistula. So media has to hypertrophy and endothelium has to remain the same. So if there should not be any endothelial hyperplasia. That's the goal. Now even if the fistula has matured, even after the fistula has matured, laminar flow has been established, it can again become turbulent because of two things. One is because of arterial stenosis, because whenever there is obstruction, whenever there is an obstruction to the flow, it is going to lead to turbulence. So arterial stenosis, venous stenosis. So that is the reason why we need to identify these factors early before the fistula fails. So if you can identify arterial stenosis, venous outflow obstruction, then you can take necessary changes to make the flow back to laminar. If you see side-to-side anastomosis, the scenario is slightly different. In a side-to-side anastomosis, it is seen that the turbulence is less as compared to end-to-side anastomosis, because the flow direction, the artery, there is a distal vein which will continue the flow in the direction of the arterial blood flow. So then chances of turbulence are less when you have a side-to-side anastomosis. So more favorable hemodynamics in side-to-side anastomosis than in end-to-side anastomosis. So now the question comes, which anastomosis is better, whether it is end-to-side, side-to-side, or some people do side-to-side anastomosis and then ligate the vein distally. The problem with the side-to-side anastomosis is that it has got too many complications distally in the hand, like hand edema, venous hypertension, you can get fingertip ulceration, sometimes can lead to venous gangrene. So that is the reason why side-to-side anastomosis, especially in the distal wrist, is not preferred. You have always do a side-to-side, end-to-side anastomosis as you go distal or you go towards the wrist side. So there are many studies who have compared end-to-side, side-to-side and end-to-side with distal vein ligation. As far as the patency of the fistula is concerned, there is equivalent patency whether you do end-to-side anastomosis or side-to-side anastomosis, but higher risk of hyperemia with side-to-side anastomosis that we saw. The complications are more with side-to-side anastomosis. Side-to-side anastomosis technique with distal vein ligation, this study published in January 25 in Vascular Surgery Journal says they are slightly better patency rate as compared to standard end-to-side technique. So if you are a beginner in AV fistula surgery, you are not very confident about end-to-side anastomosis, you can do a side-to-side anastomosis in a distal fistula, radiocephalic fistula, and then ligate the vein distally. Okay, the end result is same. You are converting a side-to-side anastomosis to end-to-side anastomosis, but maybe you are more comfortable doing a side-to-side anastomosis, then you can do this as far as the distal fistula is concerned. Now, from turbulence, we have to go to laminar flow. Now the question is whether when you do an AV fistula, whether the flow can really become laminar ever again. Yes, it can become laminar, not at the site of anastomosis, but beyond the anastomosis into the vein, the flow can definitely become laminar, but it will depend on the stage of the maturation, vessel diameter and velocity of the flow. So at the anastomosis, the flow is turbulent due to abrupt change in diameter of the artery and vein, high velocity pressure from the arterial side, sharp angulation at the site of anastomosis. So you will have, all this will lead to turbulence, and this is what we hear is bruit and palpate is the thrill part of it. over the vein, away from the anastomosis, the flow can become laminar as the vein matures. If the vein doesn't mature, the flow will not. So even if you see, immediately after surgery, yesterday we saw the maximum bruit and bruit is heard at the anastomotic site. As you go away from the anastomotic site, the bruit is dampened. So that is, as the in a mature fistula, if you see, you will hear bruit mainly at the anastomotic site. If you go on the vein here, you will feel the thrill. But if you hear the bruit will be much softer. So that is the flow is become, if in a mature fistula, the flow will become laminar in a vein which is away from the, because the vein dilates, the media hypertrophies, and there is no intimal thickening. Now, how we can aid this? Because our aim is to convert, we are creating problems by adding turbulence to the system. Now, how we can aid the turbulence to laminar flow conversion? One is you could match the vessel diameters correctly, because you have a stenosis somewhere at the anastomotic site, it's going to produce more turbulence. The suture technique that we use, the angle of anastomosis, and the non-planarity of the anastomosis. So discrepancy in vessel diameter obviously leads to more turbulence and increase in shear wall stress that can lead to thrombosis, and the fistula can stop working. Suture techniques, whether interrupted sutures, continuous sutures, somebody was asking yesterday, there is no difference whether you take continuous sutures or interrupted sutures. As far as this study is concerned, published in 2023, and even our both the articles that we have published, we have compared this continuous as well as interrupted sutures. But why I prefer continuous sutures? See, these patients are all hypertensive patients. So, according to me, interrupted sutures technique will take more time, because there are going to be leaks in between the sutures unless you put the sutures very near to each other, because their blood pressures are sometimes 180, 190 plus systolic pressures. So, chances of leak are more after the anastomosis in an interrupted suture. So, I prefer a continuous suture on anterior as well as a posterior wall. Yesterday we talked about the anastomotic angle. This plays a very important role in establishing the laminar flow down the line. So what is an ideal angle? Ideal angle, as we saw yesterday, is less than 30, because that is the best angle where maturation of the fistula is faster as compared to any other angle. Now this is a good study by Lorda K, where he has compared anastomotic angles 30 degrees, 45 degrees, 60 degrees and 90 degrees. Now amongst all the four geometries, smaller the angle, less than 30, better is the maturation of the fistula. The fourth point is the third dimension, that is the non-planarity angle in a fistula. I will explain you what it is. So it's a 3D twist. As we saw yesterday, I explained while doing a radiocephalic fistula, the plane of artery and the plane of the vein. If they are in the same thing, then your non-planarity angle is less. If artery is coming from top, the vein is coming from top, artery is below, the planarity is going to be much more. So higher the angle, more is the spatial twisting of the vein that can take place when the flow, when the clamps are released. So the ideal angle is about 20 degrees. I'll just explain you here. See, the blood is flowing from here. It is going in this direction, hitting the wall on this side. Now you see the laxity of the vein here. More the laxity of the vein which is joined to the artery, the twist in the artery is going to be more. The third dimensional movement of the vein is going to be more. So that is the non-planarity. So you keep the non-planarity angle as low as possible. Ideal is 20 degrees, and that is best achieved when you have angle of anastomosis less than 30 degrees. So this aspect we have to remember, because this is going to produce, again going to produce more turbulence inside the vein. So maturation will get affected. So these hemodynamic things one need to understand before we venture into AV fistula surgery, because once you know why the fistula fails and how the anastomosis and how the angle has to be adjusted, then you can give better long-term patency of the fistulas that we are doing. So our enemies are turbulence, vibration and intimal hyperplasia. So we have to mind the angle of anastomosis, mind the vessel size disparity and mind the non-planarity. Thank you. So any questions on this, I'll be happy to take. If there are anything in the chat box, you can let me know. Otherwise, I'll play the video of secondary transposition. Yes?
non-planarity angle is the angle between the artery and the vein.
Yes. Yeah.
So the non-planarity angle is the angle between the artery and the vein.
No, it is not the angle between. It's the difference between the. See, the flow is going to hit one side of the vein wall. The flow is going to hit the other side of the vein wall. The vein is moving. No, that is the angle that it is the angle between the two end walls of the vein. See, it's a third dimensional twist. That is what we are talking about.
Yes, sir.
Angle of anastomosis that we have already talked about. The flow is. See, it's. Sorry. Suppose this is the artery. The blood flow is flowing in this direction. The blood flow is flowing in this direction. Now, if your artery is exactly at 30 degrees or less than that, the blood flow will go in the straight in that direction. Now, if there is a laxity of the vein here, there is going to be some vein movement. That is the non-planarity. That is the third dimension that we have to identify. So, that is, if you see yesterday's all anastomosis, there were little under tension. The reason is, once you open the clamps, we all know when we do a vein graft, suppose whenever you do a vein graft for gap in the artery, we always keep that vein graft slightly shorter as compared to the defect length. The reason is, once you remove the clamp, there is going to be a little bit of elongation of the artery as well as vein. So that is the angle that we are talking about. So we'll just show the video now. Brachiobasilic fistula. In this patient, a brachiobasilic fistula was done in the cubital fossa with a transverse incision, and the vein was not superficialized or transposed and superficialized anteriorly, primarily along with the anastomosis. As you will see in this video, there is a small problem in transposing a vein anteriorly just by dissecting the vein, as it passes between two branches of the medial cutaneous nerve of forearm. Hence, a branch of medial cutaneous nerve of forearm needs to be divided. The vein needs to be delivered out of the branches and then transposed anteriorly, as you cannot divide this fistula now, as it is a functioning fistula and the vein has got good bruit and thrill in it. And this nerve needs to be re-anastomosed before we close the skin incision. Let us see this video now. This is the transverse incision by which an end-to-side brachiobasilic fistula was done. I am feeling for the thrill on the basilic vein with my left fingers and marking the basilic vein. This is marking of the brachial artery, and probably the brachial artery going down into the forearm and bifurcating now. And this is probably the marking or the fashion in which the basilic vein is anastomosed as end to side with the brachial artery. We can feel the thrill all along the length of the medial aspect of the arm and mark the basilic vein. You see the incision is on the medial side of the vein and infiltration is done, and an exploratory incision is taken at lower end on the arm. I am not exposing the anastomosis at all, and we just need to expose the basilic vein at the lower end of the arm and then continue with the incision on the upper arm. And this is the basilic vein being exposed. It's a well dilated vein with good thrill in it, and these are the branches of the medial cutaneous nerve of forearm. As you can see, there is a bifurcation there, and the vein is going in between two branches of the nerve. We ligate all the branches of the basilic vein, the deeper perforators and the communicating branches with the muscle. Here the nerve needs to be divided and re-anastomosed. This is a deeper communicating branch being clipped and ligated. Now the nerve is separated and the 10 centimeter length of basilic vein is available to be transposed anteriorly. The divided nerve is re-anastomosis at end of the procedure before we close. Now this is a tunnel that is created in the subcutaneous plane. So this is the fascia that I am holding with forceps, and the vein is put in the subcutaneous plane and the fascia is passed under the vein and sutured to the medial edge of the incision.
So the vein becomes superficialized from subfacial plane to suprafacial plane. This continuous running sutures with Vicryl being taken so that the fistula is closed underneath, and then with irrigation you just confirm that the thin skin flap is bleeding well before we close the incision. We start closing the incision from the top with interrupted sutures of Vicryl and skin sutures with 4,0-ethylol. And then feel for the thrill all along the vein to confirm that the vein is patent and flowing well. Thank you for watching this video.
Namaskar. Today we are going to see a video how superficialization of the basilic vein is done as a secondary procedure following a brachiobasilic fistula. In this patient, a brachiobasilic fistula. You see this now, this video and what we did yesterday, tunneling is far easier and simpler. This becomes more complicated, and though this is all well edited video, so I've fitted it in 4.5 minutes, but it takes more time because the vein is already dilated. Yes. There is good thrill, big branches of the vein which need to be ligated. If you see here, I didn't use clips because I was not confident. The flow is so high. It's better that we use conventional silk or linen sutures to ligate all the branches. And any puncture in the vein here, you know, it's going to give a spurt. So, and the length of the vein is also a limitation. I could mobilize 10 centimeters of the length. Once you transpose it, as it goes anteriorly, your actual length available for the technician to prick is not going to be more than 7 to 8 centimeters. So that is also a drawback in doing secondary transposition of the vein. As far as the post-operative management is concerned, there is not much of a difference. And if you see the incision, I had taken deliberately slightly on the inner side of the arm because you don't want the incision to be exactly over the transposed vein. So we'll have to raise the flap and transpose the vein anteriorly and close the incision. So the incision goes way inside the inner aspect of the arm, yes, and the vein is, and it cannot be complete anterior transposition. You can see because there is a limitation, because there is an anastomosis down, the vein is draining into the subclavian and up. So how much you can push it anteriorly, there is a limitation to that. Not like what we did yesterday. Here it was you can go almost near to the cephalic in the arm. Here you cannot go do that in the secondary transposition.
And sir, do we advise for limb elevation, because we have done much dissection here, the facial, we have lifted the fascia. So do we advise for limb elevation or post-op?
No, limb elevation post-op is good. Sometimes you can put a drain also if you think that there was intraoperative bleeding too much, because you don't want any hematoma to be there.
Yes, sir.
You have superficialized the vein, finally the edema and everything has to settle down fast, only then the vein will be visible. So you can put a drain there for 1 or 2 days, 48 hours, and then remove the drain later on, so that there is no collection underneath. Yeah.
Thank you, sir.
So we continue our talk with the complications of AV fistula. Now this is a very important topic because everybody has to know what complications can happen, and they will happen as you start doing more and more fistula. So you should be confident of managing your own complications. It's not moving. Fistula failure, as we saw yesterday, it is defined as poor blood flow across the fistula less than 250 ml per minute, not sustained for minimum of 3 hours without recirculation. Now I explained the concept of recirculation yesterday. If the two needle pricks are too near to each other, the blood that is going into the dialyzer unit is again coming back into the vein, and the same blood is going back to the dialyzer unit. That is recirculation. So if the dialysis is ineffective if there is a lot of recirculation, and to avoid recirculation you have to have minimum gap of about 5 to 6 centimeters between the two needle pricks. So failure of fistula, primary fistula failure is failure to mature at 12 weeks. Though in clinical situation, if you do a good AV fistula, fistula will mature within 4 to 6 weeks time. Again, this article of nuances of creating fistula, why do fistulas fail? Now there could be immediate failure, there could be non-maturation of AV fistula, or there could be delayed failure. Let us see some intraoperative problems first. Two problems. One, there is no backflow from the vein after transection of the vein that we saw yesterday, whether to proceed or not to proceed. It's not an absolute prerequisite. As I think Dr. Vibhuti also said, and I also told you, you can flush hyperonized saline solution, ask the assistant to feel for the thrill, and if there is thrill on the vein, you can continue with the fistula and do the anastomosis. The next problem is there is no pulsations, no thrill or bruit heard after the anastomosis is done. Then what do you do? Our dictum was no fistula, no thrill, no fistula. So how do you check why there is no fistula? As I said, there has to be either bruit or thrill if everything is working well. So look for any of these problems. Either you have taken one of the back wall sutures, inadequate adventitia clearance, which we saw yesterday. After clearing that adventitia, the thrill also increased substantially. There could be torsion or kink in the vessels, especially when you are doing brachiobasilic transposition, because it's a tunneling thing. So, and that is the reason why I pulled the vein when it was fully filled with hyperonized saline, so that you avoid any twists and turns. Because when you are pulling the vein, you never know. If it collapses when you pull, it can easily get twisted. Too much of traction on vessel will lead to collapse of the vein at the anastomotic site. Improper sighting of arteriotomy, that could be another reason, because improper sighting of anatomy will lead to more tension on the anastomosis itself. Also look for, it can happen, you can get immediate soft thrombus at the anastomotic site, especially if in atherosclerotic vessels you have intima which is already started separating from the adventitia. So look for that. Any facial bands that is causing outflow obstruction for the vein, or there is a proximal obstruction higher up because you miss that central venous stenosis, and that is the reason why, because of the back pressure, you will not have bruit or thrill. Or a non-distensible vein. I mean, the vein which is already recanalized secondary to thrombosis is not going to distend, and there is not going to be dilatation of the vein, and that fistula is not going to work. Eventually the fistula will fail. So all these things you have to check. If you have checked everything and everything is in order, there is no reason why there should be no, or the patient's blood pressure is low. If a patient is hypertensive, gone into hypertension, then there could be a problem that the bruit or thrill can disappear. Immediate failure, either improper selection of the patients, technical failure, or early thrombosis. Now see this small technical problem here is a small branch of the vein after the anastomosis. So the fistula is done somewhere here, and you can see this small vein branch of the vein which was not ligated, and that is causing the obstruction because it's pulling the vein on opposite side. So it can happen. This is classically seen in the image on the left here, that how that vein is causing obstruction to the outflow in the vein. So that needs to be clipped and ligated, and the problem will get solved. Thrombosis can happen either within 48 hours, early thrombosis within 2 days, or late thrombosis. If it's a early thrombosis, you always re-explore, do embolectomy, and then after patient has an thrombosis of the vein, then it's better to hyperonize the patient in post-operative period. Otherwise, we don't continue with heparin. Now this is a video. As you can see here, soft thrombus after entoside fistula. This is after embolectomy. And what you can do here, you normally have clipped one of the side branches or one of the potential accessory veins. So don't disturb the fistula. If there is no thrombosis on the arterial side, don't disturb the fistula. As you can see here, there is thrombosis on the venous side. So I opened that clip, and from the side clip, you can do an embolectomy passing a Fogarty catheter without disturbing the anastomosis. You pass the catheter both on the cranial side as well as to the fistula side, and then flush hyperonized saline to check that everything is working well, and then you just clip that vein again. It saves a lot of time rather than opening the anterior wall of the anastomosis and removing the clot. But this is possible only if there is no thrombosis extending onto the arterial side. If the arterial side is also thrombosed, then you will have to open the anastomosis. Non-maturation of fistula could be either because of juxta-anastomotic stenosis, accessory veins which have developed, or because of central venous stenosis. Now juxta-anastomotic stenosis, either it is called as index 1 lesion or index 2 lesion when it happens on the vein. The classic area where it happens is where the vein swings at an angle. That is a common site where you will get an juxta-anastomosis stenosis. It could be on the radial side. It could be because of your clamp injury also, that the clamp is too tight pressure. Then it can cause an stenosis secondarily at that area. So abrupt disappearance of bruit or thrill after a certain point, then you have to suspect that there is a stenosis at that particular point. So the thrill at the arterial anastomosis has to be felt throughout the entire outflow. So that is why yesterday we checked on the vein. It's not only at the anastomotic site, but you check the vein as it goes proximally. You should have a decent length of the vein which is showing good thrill. Accessory vein developing, yesterday we saw how the accessory vein has to be identified and ligated. So within that incision, about 1.5 inch incision that you take, you really dissect and see if there are any branches of the vein in nearby area which you need to clip. As we said, the problem for the accessory vein comes when it is within about 5 to 6 centimeters from the fistula site. The veins which are higher up doesn't matter because their flow is going in opposite direction. Doesn't mean that they will not develop secondarily. They can develop secondarily, and you will require ligation of this. So how to identify that there is an accessory vein there? There is a test called as sequential occlusion test. So now you are feeling for the thrill at the anastomotic site, and this is the vein which you have joined end to side radiocephalic fistula. So I occlude with the left finger, I occlude the vein here. The thrill at the fistula site should disappear. If I am occluding here and the thrill is not disappearing, that means there is some veins, like you see in the lower picture, the branch of the vein that is draining the fistula. That is why the fistula is not, the thrill has not disappeared. So like this, you start from the wrist and go proximally, and then you can get an idea in which area of the vein you are having an accessory vein. Of course, if you have a duplex Doppler, you can do a duplex Doppler to identify, but this is a clinical test to identify accessory vein, and then you can take necessary steps to ligate it. Now this is what we talked about yesterday, non-maturation of fistula because of multiple side branches, and there is a described procedure. As you can see here, this was a young female. We did an radiocephalic fistula, and there were so many branches that develop beyond. If you see here, almost till the mid forearm there were no branches, but after that there were so many branches, and there was not adequate flow in the cephalic vein. So what we did, I'll play this video. I don't know whether I can play this video again. Yeah. So what we did is we ligated multiple side branches. I can do a nice Doppler mapping. Put a venous tourniquet, map the veins, and you ligate all the veins, which are all the side branches, so that the main cephalic vein, the blood flow that was getting diverted into other veins will come into the main cephalic vein, and immediately you will feel improvement in bruit and thrill on the main cephalic vein. Non-maturation because of insufficient arterial flow. Sometimes there can be severe atherosclerotic in diabetic patients. Over a period of time, atherosclerotic plaques increase and there is decrease in arterial pressure. Then what do? Either you can disconnect the vein is already mature. Vein is already dilated, vein is already mature, but at the radial artery is not giving enough pressure to dilate the vein. Then you can just disconnect the fistula, and as you can see here, you loop the vein and join it with the brachial artery just below the cubital fossa. So you increase the arterial pressure, and you use the same vein for anastomosis. Because if you do a new fistula, you have to wait another 3 to 4 weeks for the fistula to mature. Your vein is already mature, you just have to increase the arterial pressure. So that is how it can be done. Central venous stenosis. You see this picture of angio on the left side. Because of obstruction, you can see the dilated veins here. The classical signs are edema, neck vein dilatation, shoulder vein dilatation, and this is an stenotic segment. So this will we require help of intervention radiologists to tackle this problem. Sometimes it can recur also. So it is, once you do a stenting there, it is better, or balloon dilatation, it is better to follow up patient in post-operative period. Delayed failures can be because of late thrombosis, could be because of hypotensive episodes, or cephalic arch vein stenosis. Now this is an patient who came to us 15 days back at Sassoon. Somebody had done a side to side. As you can see here, side to side brachiocephalic fistula. And this is how he presented with ulcerations and edema on the hand. The fistula was apparently working well. But there was for unknown reasons, there was a thrombosis of the cephalic vein in the arm. Now once the cephalic vein in the arm got thrombosed, the entire flow from the brachial artery started going distally towards the wrist side. And he developed a huge swelling in the hand, skin discoloration, fingertip ulcerations. And what we did, we just ligated the distal cephalic vein. The proximal cephalic vein was anyway thrombosed. So this fistula is anyway fired. You will have to do a new fistula. But you see, this battery is running low. But what you see is within 8 days time, the edema has considerably reduced because it was basically venous hypertension. Cephalic arch syndrome is defined as stenosis of the central perpendicular portion of cephalic vein as it traverses through the deltopectoral groove. So there is an external compression at the deltopectoral groove on clavipectoral fascia because of the pectoralis minor muscle, and also there is a change in angulation here when the cephalic vein joins the subclavian vein. Iska battery down. Anyway, we'll continue. Yeah, it's charging now. Okay. Full screen page. Okay. So this is an example of cephalic arch syndrome. This was done balloon dilatation under, you can see a catheter here, and after dilatation the stenosis has opened up. Long-term complications, there can be distal vein edema because of accessory vein, venous hypertension. There can be gigantism of the upper limb, lymphedema, aneurysms or pseudoaneurysms, nerve compressions, fistula failure, steel phenomenon, fistula stenosis, and cardiac failures. Accessory veins, sometimes you may miss accessory vein intraoperatively, or somebody has operated and patient can come to you with edema of the hand and you need to ligate the accessory vein. And we have done it under local anesthesia on OPD basis. You don't need to take the patient to theatre. You see this video, bruit on the vein as well as at the anastomotic. And this is a marking of an accessory vein. So you can hear a soft bruit on the accessory vein. Now that is why the patient has got edema on the hand. This vein will reduce the flow into the main fistula as well. So what you can do is, after local anesthesia, I have given local anesthesia here, you take a stitch with 3,0-ethylene suture, a deep bite, go under the vein, come out on the other side, and you can take a couple of stitches like this just to occlude the outflow, the accessory vein. So you don't need to really open the skin, identify the vein. You can just do this blindly as an office procedure, OPD procedure, and then check after with the Doppler that your vein is occluded enough and the bruit has disappeared. So this has worked well in my hands. I've done it for a couple of my patients. When patients come after, you see, accessory vein can develop not immediately but can develop after a couple of months also. So then you don't want the patient to come back. You have to take him fitness again, go back to the theatre and do it. So this is how you do it. And then after, I think I'll just fast forward the video. Yeah, so I've taken 2 stitches. So you check again now. Important point is sometimes the accessory vein is the main drainage vein for the fistula. And after ligating the accessory vein, the fistula bruit can disappear. So that is what you have to check, that the bruit is not disappearing after ligating the accessory vein. You can check it. Now you see here I am putting a Doppler on the accessory vein and now you cannot hear the bruit. So that means we have successfully ligated that part. The vein and the flow has disappeared. Venous congestion, again prominent veins, dilatation, forearm edema, arm edema, skin discoloration, some limitation of hand movements and pain during hand movements is common with venous congestion. You can get gigantism like this. Now this fistula was done in a proximal fistula done in a lady where she developed a central venous stenosis secondarily. Now after central venous stenosis you can see the amount of dilatation, amount of swelling she has on the hand, and we advised her to close the fistula immediately, otherwise eventually the fistula is going to rupture. But somehow she disappeared and she's never come back. But we have seen a patient like this. She was not able to walk also and was on completely wheelchair bound. Lymphedema, a very common complication after proximal fistulas, more common with proximal fistulas, happens obviously because of transection of lymphatics, or if there is a local hematoma subcutaneously, which can again compress lymphatics. So avoid transverse incisions. As I said, generally take longitudinal incisions, and you can take a gentle S extension on both the sides to raise flaps. Aneurysms, it can be either plain aneurysm or a pure aneurysm or a pseudo aneurysm. We know the difference. I know when it involves all the three walls, it's real pure aneurysm. If it's involved only one wall, then it's a pseudo aneurysm. So it can happen at puncture site, where they are puncturing with the needle every time for the dialysis, or it can happen at fistula site. Now there are two different techniques of accessing the fistula. What is known as a buttonhole technique, and second is a rope ladder technique. So rope ladder technique is every time you make pricks at different sites, and buttonhole technique is you are pricking the same site again and again for accessing. So in a buttonhole technique, there is likely to develop a aneurysm at that site. So what are the indications for surgery? Is overlying skin becomes thin and atrophic, there is ulceration of the skin, there is partial thrombosis of the fistula. It has happened in combination with central venous stenosis, and that these are the indications where you have to intervene before the fistula or before the aneurysm ruptures. So this is a classical example of a aneurysm happening at the puncture site, and this can easily be avoided with a rope ladder technique. So if the technician is used to, because it's not easy, the technician has to be trained to pick the vein every time at the new site. It is very easy for a technician who is inexperienced already. He knows the puncture site, you just have to put a needle there. So they will try the easiest way out to put needle there and there itself every time now and then. Especially patient is coming for dialysis 3 times a week. You can imagine the same site is being punctured 3 times a week. So change to rope ladder technique to avoid puncture site aneurysms. Aneurysm can take place at the fistula site also. And this is an example of a fistula site aneurysm, end to side radiocephalic fistula. So we excise the aneurysm completely, sacrifice the radial artery here, and 2 ends of the radial artery we reconstructed by putting a vein graft. Long-term complications, neurological complications, they are well known, right from injury to the superficial nerve, injury to the median nerve, injury to the ulnar nerve. In brachiobasilic transposition, you can have injury to the medial cutaneous nerve of the forearm. So incisions should not cause nerve paths, do not infiltrate into perineurium at all. Especially this happens when in proximal fistulas you are doing, because it's a brachial artery, you are dissecting the brachial artery, the patient will complain of pain because the median nerve is next to it. So don't be tempted to infiltrate more into the perineural sheath there, because immediately it will give relief, but later on it can cause complications, and avoid diathermy near nerves. Now this is an interesting case referred by one of our plastic surgery fellows. He saw this patient where a proximal fistula was done at the elbow level, and this is how the patient presented. You see the complete forearm atrophy here, gangrene of the little finger, and when we explored, it was a side-to-side radiocephalic fistula which was compressing the median nerve here. So that is secondary to compression of the median nerve. He had developed wasting of the forearm muscles. So what we did, we converted the side-to-side fistula to end-to-side fistula, ligated the distal cephalic vein. The fistula could be silent. The fistula was working when the Bruy thrill was there. So we just ligated the distal vein. We also released the carpal tunnel. And surprisingly came back 6 months. Of course, the little finger had to go, and he came 6 months down the line. You can see improvement. He was not able to move his fingers before, and now he's got good improvement. You can see the diameter of the forearm has also considerably improved. So if you catch them early, the neurological complications can still be reversed. Fistula rupture, the most dreaded complication. I was talking with me, Dr. Giri and Vibhuti, we were talking yesterday, like we get replants, I don't know for what reasons, in middle of night. Fistula rupture always happens in middle of night. They will come at 2 a.m., 3 a.m. with a fistula rupture to the casualty. And this is a patient where a fistula was done outside without doing preoperative ultrasound. He had a central venous stenosis secondary to catheter, which was removed 15 days back. And without checking that, a fistula was done at the elbow level. So I don't know what type of fistula it was, whether it was end to side or side to side. You see this. nicely dilated veins in the neck as well as in the hand. And when I explored this side, it was a nightmare because I couldn't identify the brachial artery at all. There were a lot of fibrosis there, a lot of edema in the hand. So I just identified the vein which was joined to the artery, the cephalic vein, and ligated the cephalic vein and divided the cephalic vein, but I couldn't identify the anastomosis there. And this was the picture sent by the patient 15 days down the line. Fortunately, the edema settled down nicely. Nothing was done to the central venous stenosis, but probably it was a partial obstruction, but with sudden increase in the flow, there was edema in the hand. And otherwise, this fistula had actually ruptured at this side. So if you see the previous video, I first explored at the anastomosis, couldn't find anything here. After ligating the cephalic vein, still there was some communication and the vein was bleeding at the mid-arm also, where the puncture site was made for dialysis. So I had to take another stitches here also to ligate that vein. So it's not easy when the fistula is ruptured and there is a lot of edema. Another patient presented to us with proximal AVF aneurysm rupture, and here the skin was so bad, as you can see here, we had to resect the skin, some part of the skin along with it, reconstruct the brachial artery with a vein graft, a Y-shaped vein graft for radial and ulnar, and then we had to do a local transposition flap to cover the vein graft. Another patient presented to us, all these ruptures more common with proximal fistula. You can see a rupture hole there, and on exploration you see that is what I talked about. You see this, we had to excise the whole thing. You see this fistula, this is thrombosis of brachial artery, vena comitant, and this is the median nerve here. So this fistula was done as side-to-side fistula with the vena comitantis of the brachial artery. I don't know why they couldn't find any superficial veins here, but after thrombosis had developed, this fistula burst. And this is how you see after the vein had to be ligated, artery, we did embolectomy, removed the clot within the artery. This was the rent in the artery, side-to-side anastomosis. So this was the original incision of the artery. And we could just do a end-to-end anastomosis after resecting this segment and could primarily close the skin. This was a recent case which we did about a couple of days back. Steal phenomenon, which is very common, what is known as dialysis-associated Steal syndrome. Incidence is about 1 to 8% more common with large diameter fistulas, proximal fistulas, diabetes mellitus, female patients, history of peripheral vascular disease. And there are, this slide is moving slightly later. So it all depends on how the fistula is fed. Now this is inflow artery, that is pressure P, Q and R. So there is a disturbance in inflow pressure, there is a retrograde flow coming from the distal radial artery feeding the fistula, which can lead to Steal phenomenon. Because when there is a distal artery feeding the fistula, the flow to the fingers is obviously going to get reduced. So then you are going to have a Steal phenomenon. And there are 4 stages of Steal phenomenon. I will not go into details. The signs that we need to watch out is coldness, numbness in the fingers, pallor, pain during AV fistula, especially when patient is ongoing fistula and patient complains of pain in the fistula. That's the first sign that you have to suspect that there is likely to be Steal syndrome. Obviously, if not treated well and neglected, it will ultimately lead to nail changes, ulceration and gangrene. So surgical options include all these procedures, that is drill, pipe procedure or Rudy procedure, or ligation of AV fistula or banding of the inflow of the fistula so that you reduce the diameter of the fistula. Now this is what is drill procedure. You ligate the artery distally and you put a reverse PTFE graft or a reverse saphenous vein graft or a PTFE graft from proximal artery to distal artery to increase the distal flow. So it is known as distal revascularization and interval ligation. So you put artery here and put a graft from proximal artery to distal artery. Your anastomosis and outflow remains undisturbed. Now this is proximalization of arterial flow. This is exactly what we talked about yesterday. That's the reason why we say in a proximal fistula with atherosclerotic vessels, avoid large diameter fistulas and lower the fistula anastomosis. So you go to the radial artery rather than doing it with the brachial artery so that your ulnar flow is at least intact and chances of Steal phenomenon go down. Now this procedure, which is known as a pipe procedure, is they put a proximal PTFE graft right from artery to the vein. So you increase the flow here, and that is, once you put a graft here, the collaterals will develop distally and the steel will reduce. Next is Rudy procedure, that is revision using distal inflow. Now this is exactly what we do in a grass fistula. See, they have done a brachiocephalic, suppose this is a brachiocephalic fistula and this is the distal artery. They have put a graft, interposition graft from the distal artery to the fistula vein, okay, and ligated this fistula. So what has happened is the branches of the artery here, the collaterals are likely to develop and the flow distally will improve. So that is the reason why the grass fistula was described originally, that you lower the anastomotic side, then chances of steel will automatically go down. So here by ligating this, they are trying to convert the anastomosis from proximal to distal. So prevention is the key as far as steel syndrome is concerned. So you have to do careful when mapping duplex imaging, and in high risk patient, avoid a distal brachial artery based procedures. Limit your arterial anastomosis to 4 millimeters. So if you have a severe atherosclerosis in radial and ulnar, we talked about maximum 5 to 6 millimeters in brachial artery. I will do it 4 millimeters if there is severe atherosclerosis. Or then you can consider this procedure. But I was talking with our CVTS colleagues. These are theoretical described procedures, because see, even for interventional radiology procedures, they are very costly. Patient may not afford that, because if you are going to put a PTFE graft, if you are going to do a balloon dilatation of subclavian vein, the catheter itself is going to cost, consumables are going to be in lakh of rupees. So practically it is not possible. I was telling somebody yesterday, in lakh of rupees we can do 4 fistulas or 5 fistulas maybe. So it's practically for our country, in our scenario, it's better that if the fistula is not doing well, there are complications. You ligate that fistula, go to other side and do a new fistula, much faster and much cheaper for the patient. These are theoretical procedures that can be done, but nobody does these procedures in our scenario because of the cost constraints. Reduce quality of dialysis during fistula, suspect and fistula stenosis, prolonged bleeding after rupture, because you know that they prick the vein and there is a tight pressure dressing given there. If there is a prolonged bleeding from that, that means there is some stenosis of the fistula outflow vein and pain in the fistula. So these symptoms you have to watch for, you have to ask for specifically, and if there is, then you need to re-evaluate the patient to identify the problems earlier. Cardiac failure, best to be avoided. So the dictum is EF less than 20, don't do any fistula in that patient. You have to either ask them to go in for peritoneal dialysis or put a permacath and tide over the situation. So don't do a fistula, because suddenly increase in venous pressure, patient is going to go into failure. So monitoring of complications, monitoring of the fistula that you have done, surveillance is very important, and that is what we lack in our country. And that is the reason why the fistula fails, and then patient probably, if he has money, he will come back to you to get a new fistula, otherwise he'll just leave it, and then that's how your increase in incidence of mortality. So these are how you identify venous congestion, bleeding from puncture site. So this we've already talked about. So the bruit can tell you a lot of information. Bruit can tell you a lot of information. It has to be a continuous bruit in diastole as well as systole. So if there is a high pitch bruit, which is a very high pitch wooing kind of sign, then there is a stenosis at the fistula. So listen to the bruit nicely, feel that you have a bruit all along the vein and thrill all along the vein. And if you examine, give some time when the patient comes to your OPD to examine the fistula, you will get a lot of information whether the fistula is working properly or not. So I hope I have covered almost all the complications that I have seen, and it will help you in managing your patients. So thank you once again for inviting me here. I'm going to share a feedback link Google form on the group after my talk. So I've got some physical printouts of the form also. So those who are present here can fill the form physically, or if they want to go on Google form, they can. So please give a genuine feedback. Don't write everything is good. Okay, I don't want that. Give your genuine feedback, because every time then we can improvise and what is lacking, what needs to be added to this, because we are planning to replicate this module at many places. I originally thought that I was doing it in Pune every time. Everybody cannot come to Pune. And when I 6-7 March, I was in Calcutta for West Bengal chapter meeting, and we did similar module there. Of course, there was no hands-on that time. Today we are in Bhubaneswar, but this is, if we keep on, if we get a genuine feedback, I can improve on further things, and more things can be added. And it is really my dream that, everybody in the country, all our colleagues, ki fistula kahan karna hai, to everybody should say that plastic surgeons. So that is what we should be aiming for. So everybody should start doing AV fistulas. Any problems you have any time, you can call me also directly, no problem. Intraoperatively also, if you are facing any problems, or I am available on WhatsApp. So there is, please don't hesitate to call me at all. Thank you. Yeah, questions? Yeah.
Percutaneous ligation of the axis.
Yes.
And you said that we have to make sure that the bruit doesn't disappear.
Yes.
So in case it does, do we need to do anything immediately?
No, you can check that pre-operatively before ligating the vein. You can just compress the accessory vein, and if the bruit is disappearing, that means that is the main draining vein. That's the main draining vein of the fistula. Then you probably have to revise the fistula, or you have to, because once you ligate that has to be ligated, because it's going to cause complications distally. So anyway, it has to be ligated, but then you have to warn the patient, I am ligating this fistula is likely to fail. You wait for 48 hours, 72 hours. Sometimes once the other vein is ligated, this vein flow may increase over a period of time. But if it doesn't, then you need to do another fistula.
Yes, sir. And one more, sir. You mentioned a recently done case by you. There was a pseudoaneurysm, and the brachial artery you used Fogarty. So, sir, do you routinely?
Yeah, I routinely use Fogarty catheters. Sometimes in 1 or 2 cases, the vein it was not picked up on a Doppler. The vein was pricked about a week back, and Doppler said the vein is patent. I opened intraoperatively. I found a soft thrombus in the vein. So I did a Fogarty catheter, did a fistula, used the same vein for fistula, it worked well, no problem.
So
if the clot is soft, it comes out very easily, you can just pull it out like that. You don't need to put Fogarty also. If at the anastomotic side, if you open the vein and if the clot is soft, you can just pull out very easily with a microforceps. Just to confirm that everything is gone, you flush and check that there is good thrill on the vein, and then you do an anastomosis, no problem.
Thank you, sir.
Yeah?
Yeah. Sir, I am Dr. Ritesh. Very good presentation. Sir, I have some doubts. What is the size of the Fogarty, sir?
4 French.
So did you face any time rupture or something? No.
Of the balloon? Of the Fogarty? No. Of the vein?
Vein.
No, never.
No complaint. Because always our CTVS colleagues tell that we should not put a Fogarty on the veins.
No. If there is primarily you don't put, but if there is a complication, you are suspecting a thrombus, then there is no problem.
And sir, how frequently you encounter this lower limb AV fistula and its complications?
I have never done it. The problem is you do it in lower limb, more prone for injuries. Okay, and so nobody does a lower limb fistula. If at all you have to do, you can put a PTFE graft from with a proximal anastomosis to the femoral artery in the femoral canal, a loop over the thigh, and join back to the femoral vein. So either you can put a loop of reverse vein graft or a big PTFE graft.
Yeah, I just encountered 2 cases of lower limb fistula. They came with a pseudoaneurysm, ruptured pseudoaneurysm with a huge necrotic patch.
Pseudoaneurysm is mainly technical problem.
Yeah.
So it's not because of whether it is upper limb or lower limb, doesn't matter. It is the anastomosis technique that is the problem when patients develop anastomotic aneurysm. Puncture site aneurysm we saw, it's because of again using the buttonhole technique. I have never done a fistula in lower limb. I have done prosthetic grafts in maybe 2 or 3 patients, but in one patient it thrombosed in 2 months' time, other patient it thrombosed in 6 months' time. So grafts thrombose very fast. You can't.
I was also surprised when
any complication, because graft also can lead to repeated puncture. If there is dilatation of the graft, it kind of aneurysm of the graft, then there is no choice but to remove the graft. You can't repair the graft aneurysm. Here you can do aneurysmography if you have a vein wall which is good enough. But rarely, see, if the aneurysm ruptures, then there is no choice but to ligate, remove the entire fistula site and maybe put a vein graft for the artery.
Yes, sir.
So there's a question in the chat box.
Yeah.
It says some use an infant feeding tube to confirm the vein patency in the forearm. Would you
Yes.
advise it?
Yeah. I have never done it, but yes, I know people put a infant feeding tube or a soft silicone catheter just to see that patency. The best thing is you open the vein, flush heparinase saline, you feel for the thrill, that's it. Why do you want to put anything inside which is likely to damage the intima? Because the infant feeding tube might go, but infant feeding tube we all know it is rounded at the tip, but there is a side hole which has got a sharp edge. So while pulling the infant feeding tube out, you might damage an intima which you will not identify there and there itself. You do the anastomosis, but if there is an intimal damage, eventually there will be a thrombus at that site. So I don't do any intraluminal interventions.
Sir, have you ever used autologous vein graft?
Yes, so if there is nothing available, I would use an autologous reverse vein graft as a loop graft, and I've done it with a fistula to the brachial artery here, and then you put a graft to the cephalic vein at the top. So you can put a brachial artery graft like this and a reverse vein graft which is joined to the cephalic vein here. So you can do that, but better to use autologous vis-a-vis prosthetic grafts. That we do loop grafts even for our extending the pedicle till the edge of the defect in a free flap also. If you got a lower limb, suppose you have got entire length of the tibia, you don't have any exposed and you don't have any vessels. We have done that, putting it from the adductor canal, a loop graft till the edge of the defect, and then dividing the loop graft, one part to be used as artery extension, one part as a vein extension.
Sir, from which part of the great saphenous vein do we harvest in this case?
Depends on the diameter. I would prefer from the thigh.
Thigh.
Yeah.
That is what I want to know. Thank you, sir.
Any other questions from chat box? Okay, thank you. So I'll share the Google link, and physical forms are here, so somebody can distribute those who want to fill physical forms, and I'll share Google link in 2 minutes.
As in reconstructive surgery.
Seniors and my colleagues and my students. Today my topic is role of acute fistula in reconstructive surgery. As because I have chosen this platform because sir was talking about acute fistula in for dialysis workup and workshop. This is not an reconstructive thing, but as the arteriovenous fistula is also is very much helpful in reconstructive surgery, that's why I chosen this topic to share with you. So arteriovenous loop is an age-old technique. It has been already established. So it is mainly in reconstructive surgery where it is mainly needed, particularly in trauma cases in the lower limb, as well as post-irradiation in head-neck region, or recurrence when the tumor ablation surgery is being done, or multiple previous operations already being done where the vessels are less. In those cases, we can extend the pedicle, we can make our desired way to how to move, where to put the artery and where to put the vein. So we can use the arteriovenous loop to create that and to reconstruct with the free flaps. So microvascular surgery, it has started. Since then, the free flap has developed more, and then more we develop, more we grow, and more we started of thinking. So then we started of thinking, why not to use the arteriovenous fistula as a pedicle to reconstruct and to do microvascular surgeries in various reconstructive defects. So these are the areas where our reconstructive defects are usually required, like in diabetes patients or in chronic infections or post-trauma, multiple trauma, where the vessels are injured or single vessels. In those cases, this arteriovenous fistula is very, very helpful. Where I have already told that if the vessels is depleted, in those cases we can use any vein or superficial vein to the deep artery to make a longer venous conduit, and then we can use it as an artery and the vein for our free flap surgeries or reconstructive surgeries. So these are the physiological which you already know because of sir just previously sir has told everything about the arteriovenous loop regarding the fistulas. These are the various methods where you can use the arteriovenous loop as a AV fistula, where you can use an interposition venous graft and without disturbing the arterial flow we can use an end-to-side flow to do an arteriovenous loop, or else we can do end-to-end to make a good big loop. Using the same vein also you can use, but in that case the superficial vein should be isolated more distally to the artery. Then you can do, and you can have an artery and vein loop as sir told just last, where he has done a venous loop from the great saphenous vein into the femoral artery. You can use it to reconstruct lower limb in various cases. These are the important technical points of arteriovenous fistula where you should avoid. You should, as you have seen yesterday also, sir has already shown that heparinized solution where you are you should be filling the vein, where transposing it. It should not get twisted and it should loop gently over the artery, and there should not be any tension to the anastomotic side. Now we can think about whether to do it as a one-step or two-step procedure. If a one-step procedure, then interposition vein graft, it's become a vein graft. And if we do a two-stage procedure, then the maturation, or not the maturation, or at least the flow has already been developed through that loop, so that we can easily use that as an artery or as a vein. We can convert it, the arterial side as an artery and the vein side as a vein. So these are the the various advantages of two-step strategy and the single-stage strategies. And the timing is, it varies. If we go ahead with a two-stage strategies, we can think about earliest we can do from third day onwards, or else we should wait for 1 week, or we can wait further to 21 days. But the problem with the two-stage strategies is that hospital staying, you will have to prolong the hospital stay. But as our today's scenario, it is go ahead with an one-stage procedure. So one-stage procedure is also can be done in the same sitting, when we should do the vascular loop first and then wait for 1 hour, or we can go ahead with an harvesting of the flap and then we come back. By that time, when we harvested the flap, the loop already being matured, and during that time we can use it as an artery, as a vein, as a pedicle. So these are the arguments is already said. Then preoperative planning is very mandatory, that we should be doing an angiography, because it may be an post-traumatic or vessel depleted limb, or where your operation already being done for neck vessels may not be good enough to do withstand the artery and vein. So we should do an CT angiography, and we should have a thinking about we should be very much think about arteriovenous loop from the very beginning when we are planning preoperatively. So this is what I have told, that 1 hour buffer can maintain that arterial flow. So this is one case where you can see that there is no vessel depletion, but the problem here, the indication was the shorter venous arterial pedicle. In those cases, what we can do, we can easily bring our cephalic vein and ligate it interdistally and loop it into the radial artery, so that it can come to the, it can prolong the artery, and so that your pedicle reaches easily. And we did this case, but in this case, what we did an loop fistula, but the pedicle artery was very, very small. So what we did, we anastomosed with the one of the terminal branch, one of the side branch of an cephalic artery, and kept the loop in situ, and then we did an arterial anastomosis, and we took another vein to drain the vein, and then later when the flap survived, later after 3 months, we revised that loop, arteriovenous loop. So this is one case where you can do, where your pedicle is short. Here also, in the various knee defect, your recipient vessels is posteriorly, you'll have to go to the popliteal artery, or else you'll have to go to the medial genicular artery, which may not be adequate in size to give a good arterial circulation. So what you do, you can easily harvest the great saphenous vein very distally and loop it into the superficial venous femoral artery and make a prolonged pedicle, and you can easily convert it into a vascular access, and you can use as an ALT. We have used the ALT as an artery. So in conclusion, AV loops are essential tools for the vessel depleted patient, or meticulous technique and strategic planning are the key to the success, enable reconstruction in cases of previously deemed non-reconstructable areas. So the golden rule is the beauty of the AV loop concept is that any impairment of flow, thrombi, spasm or kinking can be corrected before the flap pedicle are divided. Thank you. Any question? Thank you.
Now stop streaming and proceed to the AV Fistula quiz for the participants present here. We shall come back for the panel discussion on the online streaming and shall let you know the updates on the WhatsApp group. I now invite Dr. Ahana Bandopadhyay to proceed with the quiz.
Ma'am will explain you the rules or how we are going to go about the quiz session. So it is, I guess all of you have been provided with the delegate file or something. You can keep that, and we'll distribute the papers on which you have to write down.
Sorry for slight delay. I hope everyone is settled in. Okay. Yeah. So before we start, I'd first like to thank Sir, Giri Sir, for giving me this opportunity, because this was a chance for me also to read so that I could make the quiz. I'm Dr. Ahana. Initially, I was slightly uncertain as to what sort of questions should we put in such a niche specialty quiz. But I think after yesterday and today's talks, I think everybody is going to do very good in the quiz. Sir's videos are absolute gold. So we are very happy that he has been here with us, and his talks are an institution themselves. We want all of you all to do well. So we have a mixed bag of questions. We'll begin with some easy questions, but in there, obviously in between, we'll have some hopefully difficult. But I'm sure everybody will do well. So we have 25 questions, 1 mark for every question. A couple of questions have 2 parts in them, but the total of it would be 1 mark. There's no negative marking. And you'll have 30 seconds for every question before we move on to the next question. So is everybody settled in? Should we start? Okay. So I'll start with the first question. There are some MCQs and there are some questions which don't have, wherein you have to write maybe 1 or 2 words. So it's very clear. There will be no confusion as such. So accordingly, if it's an MCQ, you can just write the option. And if we want you to write something in an order, then you just write it briefly. That's it. It will be understandable once we start. So we begin with the first question. What is the order of preference of AV fistula as per the NKF KDOQI guidelines, depending on the site of anastomose. This is a simple question. It was mentioned by sir yesterday, as well as Vibhuti sir as well. So we have brachiocephalic, radiocephalic, prosthetic grafts, and brachiobasilic transposition. So you can just write in whatever order, A following B, following C, following D, for an example. Just with an arrow you can write what should be the order in which the fistulae should be preferred in a virgin case.
I'll start.
We have
5 seconds left.
Brachiocephalic, radiocephalic, prosthetic grafts, and brachiobasilic transposition.
I guess we can move on to next question.
So we move on to the next question. This is another very simple one. The ideal AV fistula should have all except long-term patency, easy placement, minimal primary failure rates, or a late maturation. We are still warming up, so we have simple questions in the beginning. For MCQs, we can just write the option number or letter.
10 seconds left. You can move on to next question.
Okay, we move on to the next question. I'll read it out for you all. So, according to the Fistula First initiative, which of the following is the criteria that comes under this initiative? It was a National Vascular Access Improvement Initiative that was taken. However, it was discussed yesterday that we don't follow this approach anymore. But I think it's still important to know what it encompasses. So, does it say to create AVF in 75% of the newly diagnosed CKDs and have a functioning AVF within 12 months of before anticipated need for dialysis? To create AVF in 75% of CKDs and create a functioning AVF 6 months before the anticipated need for dialysis? To create a fistula in 50% of the newly diagnosed CKDs and have a functioning fistula 6 months before the anticipated need? Or to create a fistula in 50% of the CKDs diagnosed and have a functioning fistula 12 months before the need for dialysis? Discussion you can make. I hope the question is clear. If any confusion anytime during the quiz, you can just raise your hand and voice it. No cheating. Everything is visible. Yeah, so we'll move on to the next question.
Yes.
The fourth question. Which of the following does not belong to the criteria for timing of the placement of AV fistula according to the National Kidney Foundation guidelines? A creatinine clearance of less than or equal to 25 ml per minute, a serum creatinine of less than or equal to 5 milligram per deciliter, within 1 year of anticipated need of dialysis, or a estimated GFR dropping below 15 ml per minute. I think they are not as theoretical as they appear. Many of them can be deduced with some logic if you read the options well.
And I guess this was discussed yesterday specifically by nephrology sir, also Sandeep Panda sir and Parag sir also.
I promise there are not many extremely theoretical questions, and most of them, if you read them, you will be able to deduce. Going on, sir, going on.
Ten seconds left.
So we'll move on to the next question. Name the marked structures in the schematic diagram of a distal radiocephalic fistula. So we have a schematic photo that has the cephalic vein radial artery visible. There are two structures which have been marked A and B. Just need to write A, the structure, B, the structure. Okay, to make it easy, they are both nerves. So I almost gave away the answer. They both are nerves.
10 seconds left.
The two nerves that we encounter or we need to keep in mind during a distal radiocephalic fistula, especially A.
You can move on to next question.
Okay, so moving on to the next question. Which of the following is an absolute contraindication for AV fistula? I think this sir has mentioned in his article as well as yesterday. He has spoken about it in detail. Which of the following is an absolute contraindication for AV fistula? An ejection fraction of less than 20% or impending cardiac failure, poor or suboptimal veins, advanced peripheral vascular disease with ischemic ulcerations, or a central venous stenosis in the same limb. To make it easier, one of them is an absolute contraindication, the other three are relative contraindications.
10 seconds left.
Okay, so we'll move on to the next question. This is going to be simple for everybody. Which of the following is not part of the rule of 6 for maturation of an AV fistula as per the KDOQI guidelines? Vein within 0.6 centimeter of the skin surface, external diameter of vein more than 6 millimeters, a relatively straight segment of easily accessible vein for cannulation at least 6 centimeter, or a blood flow of more than 60 ml per minute to support dialysis. So I think this everybody should get right. Okay, so I think everybody is done. So we'll move on to the next question. Again, something that we have been thinking and hearing about. I gave away the hint already. So anastomosis of the perforating vein between the superficial or the median cubital vein and the deep venous system to the brachial artery or radial artery just after its takeoff in an end-to-sign fashion. This was originally proposed by a person. What is the name of this particular AV fistula? I think everybody should know this. We talked about it today as well. We talked about it yesterday as well. So this picture on the left, that is what the person had done and published in his original article.
Okay.
It is a now commonly many people do, so it's not something very uncommon. So we'll
Next
move on to
question.
the next question. A 48-year-old underwent a left brachiocephalic AV fistula creation. After 1 hour, he developed severe pain, paresthesia of his left forearm and hand, with inability to move his fingers and wrist. Clinical examination shows a paralyzed hand, which was pulses were palpable. Name this dangerous complication. So we need to reread the symptoms and signs, because there is something which tells us
Yes. 10 seconds left.
what it could be. Mind you, in clinical examination, pulses were palpable and hand was warm.
You can move on to next question.
Okay, so we are moving on to the next question. A technical and safety feasibility study was recently conducted in Germany to create an arteriovenous fistula for dialysis using a novel robotic microsurgical system. Name this robot. So they did this study. They performed 3 cases of AV fistula using a robo, and if anybody, this was also, it was there in social media as well quite a lot when it was done.
You can move on to next question.
Okay, so moving on to the next question. In 2025, the WHO officially recognized the World Kidney Day, underscoring its global role. This year, 2026, the day was celebrated under the theme Kidney Health for All, caring for people, protecting the planet, marking 20 years of global action. Which day is it celebrated every year? So the hint is that it is already celebrated this year, within the first quarter. So you can either write the date this year or the day we celebrate it every year. It was again widely there in newspapers.
5 seconds more.
This logo was also the one that was being popularized along with the day's celebration.
You can move on to next question.
Moving on to the next question. Name this pioneer of vascular surgery who performed the first successful AV fistula for dialysis. Some names were told yesterday by Sir during the surgery, as well as some of the other faculty had also mentioned in the talks, in the introductory, in the beginning talks of yesterday. So who is this pioneer of vascular surgery who performed
5
the
seconds
first
left.
successful AV fistula for dialysis?
You can move on to next question.
So moving on, I hope everyone is comfortable. Moving on to the next question. During a thrombectomy procedure for a thrombosed AV fistula, contrast extravasation was noted at the site of balloon angioplasty as seen in the picture B. A repeat venogram showed the following picture in the picture C. Name this pathology. I think this is again very simple. Everybody should be comfortable answering this. We want everyone to answer well so that we have tough competition. The prizes are good, I think. So we want people to do well. So name this pathology noted in the picture C.
5 seconds left.
This is a very common, one of the common complications that can be encountered following fistula.
Next question.
Okay, we'll move on to the next question. So name the type of this AV fistula and the marked structure in the schematic diagram of this distal AV fistula. It is a distal AV fistula. We want the name of this distal AV fistula, how it is called as, and the structure that has been marked by the star. This was also talked about yesterday. Most of all the questions have been mentioned and discussed yesterday. So to give a hint, this structure is a tendon. I gave a very big hint. So now it should be even more easier.
5 seconds.
Answer.
You can move on to next question.
Okay. The time from establishment of fistula to the first occurrence of fistula thrombosis or the need of vascular surgery to restore fistula patency is called as primary failure, primary patency, secondary failure, or secondary patency. Please read the question well. From the establishment of the fistula to the first occurrence of fistula thrombosis.
Five seconds. You can move on to next question.
Okay, so moving on to the 16th question. The HERO, hemodialysis reliable outflow graft, is an important option considered in failing AV fistula or AV graft or catheter dependent end-stage renal disease patients. What is the arterial inflow and venous outflow sources for this graft? Meaning, to which structures do we join the both ends of the graft, to keep it very simple? What is the arterial inflow and the venous outflow for the HERO graft? This is one of the newer advances in AV fistula surgery.
You can move on to next question.
Okay, moving on to the next question. The ellipses vascular access system is a minimally invasive system that uses a catheter to create a forearm fistula using thermal energy. The fistula is created between which two structures and in what orientation fashion, meaning end to end, end to side, or side to side. This is the catheter, the device that they use. They create a fistula using thermal energy. This is again something that has been published in the last couple of years. In some centers in the world have done few cases. What are the two structures? Till now has this energy system been used for most commonly? The artery and the vein.
questions ready है
हाँ questions
immediately कर देंगे साथ और संतन को बैठा दें.
I've tried to make sure every picture has some hint, so that at least you can use some logic and answer most of them. Okay.
Yes, you
So
can
we'll move on to the next question. Which of the following is considered the most common site of thrombosis in a brachial artery to transposed basilic vein fistula? So we have marked the characteristic usual sites of the vein following the anastomosis. So out of 1, 2, 3, 4, which site do you feel is the most common site as per literature, whatever cases have been documented till now, which site has been found to carry the maximum risk of going into thrombus in a brachial artery to transposed basilic vein fistula? Are 10 seconds over? Okay. So moving on to the next question. Which of the following is false regarding the ulnar to basilic arteriovenous fistula? It has a prolonged maturation time. They have excellent patency rates. The patency of this fistula would be higher in patients with a previous functioning radiocephalic fistula. The Society of Vascular Surgery guidelines recommend a UBAVF formation when cephalic vein and radial artery are unusable. So which of these following statements regarding a ulnar basilic AV fistula is false?
You can move on to next question.
So we have the last 5 questions left with us. According to the KDOQI 2019 guidelines, which of the following is not an indicator of dysfunctional AV access? A drop in access blood flow by 25%, a reduction in access blood flow below 400 ml per minute in an AV fistula or 600 ml per minute in a AV graft, early stoppage of bleeding following needle withdrawal, or repeated difficulty with needle cannulation. Which of the following indicates a dysfunctional AV access? This was talked about today morning, just 1 hour back. So again, a very simple, no-brainer question.
Five seconds. Name is Yes.
So I think we can move on to the next question. As per the KDOQI 2019 guidelines, which of the following is not an indication to use a central venous catheter for a short-term duration? Please, I'd like to stress on central venous catheter indication for a short-term duration. A fistula or a graft created but not ready for use and dialysis is required. Acute transplant rejection or other complications with the patient requiring dialysis. Multiple prior failed AV accesses with no available options, or a patient who has a living donor transplant confirmed with an operation date in the near future but still requires dialysis. So in which of these case scenarios would you consider putting a central venous catheter for a short-term duration? This is a guideline according to the KDOQI.
Ten seconds. You can move on to next question.
So the 22nd question. A 60-year-old male with a functioning radiocephalic fistula on dialysis for 5 years presented with left upper limb swelling and reduced rates of dialysis from the past 2 sessions. What is the diagnosis? A thrombosis or a stenosis of the radiocephalic fistula, a central venous stenosis, or an anastomotic site stenosis. Again, something that sir explained in the morning.
5 seconds. Next question.
Okay, we are going to the last 3 questions of the quiz. Name this modality designed to treat stenosis in the venous outflow of AV fistula and grafts for hemodialysis following percutaneous transluminal angioplasty. What is this called, basically? The design is specific. There's only one word for it. So, what is this called? It usually comes along with a atraumatic tip for insertion. Has a needle part attached to it, which is then introduced through a catheter.
Next question.
Okay. Which of the following is currently not an application of AI in AV fistula? So, contrary to what we might think, AI has already, there are huge developments using AI in AV fistula. Which of the following do you think is something that has still not been ventured into? To detect postoperative stenosis in fistula, to choose the best vein in a patient for an AV fistula, to predict maturation or failure of fistula, to monitor development of fistula allowing home-based surveillance by patients. So which of them is not an application of artificial intelligence in AV fistula surgeries?
5 seconds. Next question.
So we have the last question. So this was a 35-year-old male who presented with a primary brachiobasilic fistula failure. Identify the level of stenosis, arterial, anastomotic, or venous. If you want, we will play it again. There are 3 videos. Should we play it again? Yeah, once. I'll play it again. It's okay, time is not going to be an issue. We'll play it again, no problem. भैया एक मिनट बैक नहीं हो रहा है. बैक नहीं हो रहा है. बैक कीजिए ना इसको. प्रीवियस क्वेश्चन. हाँ. Please see the first video. The first video is playing now. Now the second video. इसको फिर से प्ले करा दूँ. थर्ड वीडियो इज clear. So identify the level of the stenosis and has it occurred at the site of the artery or the anastomose or the vein. And give them 15 more seconds on that page.
I hope everyone has written their name.
So I think everybody is sorted. This is the end of the quiz. Thank you very much. We'll just go through the answers.
We'll collect the papers from them.
Yeah, we'll let you know the results shortly. We'll be having the panel discussion now. Thank you very much. I hope you had a good time, learned something. Thank you. Anyone is still waiting to give their paper for the quiz?
If any feedback forms are left with you, you can give away them also.
So the first question was, what is the order? This is, I think everybody would have got it right. So it's a radiocephalic followed by brachiocephalic followed by brachiobasilic transposition followed by prosthetic grafts. The ideal AV fistula should have all except late maturation. This is again very simple. So the Fistula First initiative actually asked for creation of a fistula in 50% of the newly diagnosed CKDs and have a fistula functioning AVF within 6 months. However, what we need to take home from this question is what Sir talked about. It is, we don't follow this approach anymore. We follow the right access, right patient strategy as per the latest guideline, which says that it is not about how many fistulae we make in how many patients. It is about finding the right fistula catering to the right sort of patient. So which of the following does not belong to the criteria for timing of the placement of fistula? It is a serum creatinine of less than or equal to 5. It should be less than or equal to 4 milligram per deciliter. This was mentioned by Sir's article, Nuances of AV Fistula. Yes, sir. All the other are true. So name the marked structures in the schematic diagram of a distal radiocephalic fistula. Again, they both were nerves. A is superficial branch of radial nerve and B is the lateral cutaneous nerve of forearm. So which of the following is an absolute contraindication? All the others are relative contraindications. So the absolute contraindication is advanced peripheral vascular disease from these 4 options. So again, Sir's article, he has mentioned, there's a table, Sir showed it also. I think it's a very useful article to go through for us to know about these things. Which of the following is not a part of the rule of 6? Everybody would have gotten this right. It is 600, not 60. So the anastomose of the perforating vein between the perforating vein and the deep venous system, it is the Grach fistula. We saw a live surgical demonstration of it yesterday. It was originally published in 1977 by Grach. हाँ सब लोग लिख दिए होंगे सर ने सब मेरे सारे क्वेश्चंस ही सब आई हैड टू सीरियसली थिंक ऑफ चेंजिंग एवरीथिंग लास्ट नाइट बट एनीवेज yes definitely that is something we think we are good. A 48-year-old underwent left brachiocephalic AV fistula creation. So I think many people would have considered steel, but in steel the hand is not warm, hand becomes cold and pulse is not palpable. So this is a very, very rare, but we should be aware of it, very unusual but possible complication, which is ischemic monomelic neuropathy, wherein it actually hand becomes paralyzed, both sensory and motor dysfunction happens, hand stays warm, pulses are palpable. We have to immediately go in and ligate the fistula. So this is a this is a limb saving procedure. The treatment is we have to immediately go in and ligate the fistula if this happens. And sometimes it has been found as per the literature that people, even after ligation of the fistula, they have still not recovered the median ulnar radial neuropathy features. So anybody wants to answer before I show this answer? Yes, sir. So Ritesh sir has told the answer for everybody. Is a Simani surgical system. Yes, sir. Yes. So, and also, sir, now they are using this for many things. This is the microsurgical robot mostly being used in plastic surgery applications. So, mic de do na sir ko mic. Yes.
JP Hong is a pioneer doing this, and he is Dr. JP Hong from Korea. I think he is more focusing on this system for AV fistula also, and for this reconstructive surgeries also.
Yes, sir. Thank you, sir. So it's a Simani surgical system. They published also, this is particularly in AV fistula and dialysis, they have published this in Germany. 3 cases have been done. This is the article. In Annals of Vascular Surgery, it has been published. So moving on, I hope some people would have gotten this right. It's happened this month, 12th of March 2026. So someone I hope would have got. You can't write March, you have to write the day. Yeah. So it's on every second Thursday of March. It happened on the 12th of March in 2026. So yeah, residents of this institute, they should know, because our Department of Nephrology, they did quite a lot to make it available. So yeah, so moving on to the next question. Yeah, I want to know what people have written for this question. Sorry, I can't hear you. Yeah.
Kenneth Charles Apple.
Very good. So, some people might think it's Brescia and Semino, but they were actually intensivists who worked in the same hospital. So, Dr. Apple, he doesn't get credit for this, but he was the surgeon who actually performed the first fistula. But when Dr. Brescia and Dr. Semino, they published it, they left his name behind. It was published in the New England Journal of Medicine. It happened in Bronx, New York, in the Veteran Administration Hospital. So this is pseudoaneurysm. Moving on to the next question. Okay, so this is a snuff box fistula, and this is extensor pollicis brevis. The time from the establishment of fistula to the first occurrence of fistula thrombosis or need of vascular surgery is called as primary patency. Assisted primary patency is the time from the thrombus to the free access survival, and secondary patency is from the time of creation to the final access being abandoned. That is, after a procedure, again the fistula has worked, and following that intervention, it has finally stopped working. So this is the hero graft. So it again, in the article also they have placed, it is one of the common photos available online. It usually goes from the ipsilateral brachial artery to the right atrium via the IJV or subclavian into the SVC. So this is the ellipses vascular access system. The photo is already giving the answer. So it is the perforating vein of the cephalic vein to the proximal radial artery. They use a thermal energy to create a short burst so that the venous wall is basically, it is destructed, and we create an access from the artery to the vein. It is created in a side-to-side fashion. This is how they have told that this is the anatomy. There is a proximity between the perforating vein to the radial artery. This is also the concept with the Grach's fistula, which we have seen already. So this is fourth segment. It is called the proximal swing segment in a brachiobasilic fistula. This is a very good article if anybody wants to go through what are the characteristic sites of most commonly sites of every fistula which are prone to getting thrombosed. So it's a good article if anybody wants to refer. So the next question is for a UBAF fistula. Most of the studies and most of the documented literature till now, whatever I could find through, they have told that they don't have excellent patency rates, from low to moderately low patency rates. This is something that we need to know. However, the Society of Vascular Surgery guidelines do say that cephalic vein and radial artery should be completely unusable for us to do a ulnar basilic AV fistula, but this is not true. Sometimes people do go ahead. They have documented as well, even if they are not like thrombosed or if low caliber is present. So this is, I think everybody should have gotten this right. Sir mentioned it many times. There has to be prolonged bleeding following needle withdrawal, which is an indicator of dysfunctional AV access. So as per the guidelines, short-term duration, all the other three are indications, but multiple prior failed AV fistula access with no further available options, it's an indication for indefinite catheter insertion or long-term, indefinite or long-term duration indication. So a 60-year-old male, again, I think everybody should have, this is a easy one, central vein stenosis is the answer for this question. So this is a covered stent. Basically, it has a metallic structure. The alloy is nitinol, which is the most commonly used composition. It is nickel with titanium, and it is coated with PTFE. So this is something that that has come up now and is considered as a good, viable, safe option as compared to a balloon in angioplasties, following angioplasties. So which of the following is currently not an application of AI? It is choosing the best vein. That is still surgeon's decision, and all the other three have been already done and documented. The last one, the last article, it was published in 25, which is to monitor the development of fistula, allowing home-based surveillance by patients. So these are good references, you can see. This was a case which was done by Dr. Tara in our hospital. Sir was there with us yesterday in his talk. So this is a case of venous stenosis, and all the contrast runs were done from the radial artery access to locate the stenosis, and the angioplasty was done from the venous side access. The stenosis was a venous stenosis. Okay, thank you very much. Thank you.
The illustrious demonstrations of all the live surgical procedures yesterday, and even all the lectures from nephrologist point of view, from interventional radiology point of view, and our surgeon's point of view. So we had a three-dimensional look for the topic of AV fistula. So today I would like to invite our esteemed panelists, Dr. Parag sir, Dr. Vibhuti sir, and Dr. Shantanu Suba sir onto the dais. Actually, it was planned to have a holistic opinion of all the nephrology, what they expect from a surgeon and what we can deliver. But today, now we will carry forward with our surgeon's point of view. What questions we have,
there is no
we can ask.
on the epineurium. It is possible to perform a much better apposition of the neural.
We will see the steps of this suture in the animal. This is the rat sciatic nerve.
When a nerve is cut, it is very important to notice how the bulging comes rapidly and makes the direct suture of the epineurium extremely difficult. In this case, it's obvious that the use of fibrin sealant in absence of sutures can solve this problem.
TSEAL simulates the final phases of natural physiological coagulation. The first component consists of fibrinogen, dissolved in an aprotonin solution. The second component consists of thrombin, dissolved in a calcium chloride solution. To seal fibrin sealant promotes hemostasis and joins tissues, thus promoting the healing of wounds. Intelligent, like nature. Coagulation begins within seconds after application to the target tissue and produces a solid hemostatic fibrin matrix, which is highly adhesive and elastic.
Patients with comorbidities, what is the first approach or the first site of fistula? Does it change according to the extreme comorbidities or elderly patient and their life expectancy, sir?
Yeah, so I think we talked about that. Life expectancy in elderly patients is a prime thing to consider whether you to go for a brachiocephalic or a radiocephalic fistula. Comorbidities, most of these patients, they are, in the study that we did, we had about more than 50% of our patients were diabetic and they had some comorbidities. So comorbidities are going to be there in each and every CRF patient. So it's the life expectancy and the expected time that patient is going to use that fistula for dialysis that will decide the location of the fistula.
Okay. So, just continuing to that, for example, a diabetic CKD patient with a failed radiocephalic fistula and small veins on Doppler, what would be the next access option which you usually do?
So we talked about brachiocephalic will be the next option. If the cephalic system is totally fired, you don't have a cephalic system, you go for brachiobasilic.
So, how often AV grafts do you use in your experience, sir, in elderly patients?
No, we don't use AV grafts. If at all, we have to use saphenous vein graft, not a, yeah.
So, regarding the anesthesia, sir, you have already...
any anesthesia is good. Block. He prefers to do it under block. I've never ever done it under block except for...
Once you have the comfort of doing under a block, you have learned the block yourself, because I am sure most of the plastic surgeons know how to give a brachial block, and they are in fact better than the anesthesiologists in giving block. So if you give a block and do under tourniquet, it's so much comfortable, so much comfortable. So once you do that, then maybe you'll probably, change to that option. But the other option of, giving local when it can be done comfortably also.
Yes,
there is not much difference, but I feel very comfortable under a block and tourniquet control.
Yes, thank you, sir. Sir, so...
and another advantage is if you give a block and you have to change your plan, suppose sometimes the patients are not very well worked out and you open up and you see the vein, the wall is not good, that site is not suitable, you want to come more proximally, again you give local infiltration or something. So you are prepared with a block, means you can come higher up, do a brachiocephalic or brachiobasilic, whatever is required, without giving any further anesthesia.
Yes, so it is mostly the surgeon's preference and the comfort and our environment, OT environment, which we have prepared for ourselves. Thank you so much, sir. So, in the future of dialysis access, sir, what innovations do you foresee? Because you are in coordination with even nephrologists, sir. You were mentioning that you started your first fistula like that from your friend. So, what do you think, sir? What are the innovations which may require our intervention?
So see, already this HERO device and endovascular AVF is being tried, so that can be that can come up in a big way. And but we are just discussing this. Even if you are going to do an endovascular AVF, like
yes, sir, we have gone through the procedure. It requires both a surgeon and an interventional radiologist in the suit.
They go through the vein and see, the endovascular AVF can be done only in cases where artery and vein are very near to each other. So there are specific sites at elbow, at wrist, where they can do an endovascular AVF. But we don't know the long-term patency because it's still in experimental phase. So we don't know the long-term patency. Whether that anastomosis is going to remain patent, whether if there are going to be any leaks from there. So all these things are still in experimental phase. As far as the advances on the dialysis side has gone, with my I have discussion with my nephrologist, the dialysis needles have undergone revolutionary changes. Okay. Initial needles, so your incidence of aneurysm formation is now much less.
Come down.
Yeah, because some needles are blunt needles also available. So you initially they have very sharp needles which they use to puncture the vein, the first thing. But once you have, if they are puncturing at one particular point, so if they are using a buttonhole technique, then they use blunt needles later on because the skin has already become thin. So that reduces the pain and the patient tolerance also goes up. So according to my nephrologist, he says the needles, also there is a lot of study being done at what angle the needle should be inserted into the vein to cause minimum damage to the flow and fistula. Because see, needle, again, we come back to hemodynamics. Introduction of needle into a flowing vein causes turbulence.
Create a turbulence. Yes, sir.
Yeah, it will create a turbulence. So how to create less turbulence when you insert the vein? I mean, insert the needle into the vein. So that is also being studied. So I think that those differences are going to be really revolutionary for the patient. See, finally, we have to make sure that the patient is comfortable on dialysis because it's not easy. He keeps a limb in a particular position and he has to lie down like this for 3 hours. Just imagine that if you are allowed, you are told that you have to keep this limb in this position for 3 hours and don't move this limb. Even for us, it is impossible. For a patient, it's going to be much more. He's already
with him,
has many problems.
Sick patient with all his underlying things, so it is more difficult. Yes, sir.
So here we many times talk about the surgical skills deciding the patency, but the technicians do play a great role after the fistula is created. I have seen some technicians where the fistulas work much longer, and there are many where people come, even if the fistula is very good, within say maybe 4 or 5 cycles, it thrombosis. So that size of the needle, the angle where you penetrate, and the expertise to get it in one prick, that is more important than the fistula creation itself.
Yes, sir. As you were mentioning yesterday also, both of you, sir, that even after 5-6 years of good fistulas, they go to a center where they are no good trained technicians and they come back with a fired fistula. Yes, thank you. So, one more question, sir. When fistula shows poor maturation, like in the follow-up period when we are doing the surveillance, so what should be the ideal approach, sir, or what do you follow yourselves, like interventional radiology approach just first and then our intervention, or what is your approach towards that, sir?
No, if the fistula has failed to mature, first you have to find the reason why it has failed to mature. So you have to look thorough evaluation, clinical evaluation of the patient, of the AV fistula, like the parameters I told, plus duplex ultrasound to find out any stenotic lesions or any outflow obstructions, why the fistula is failing to mature. If you have ruled out that and there is nothing that you can correct, then probably, see, we were just discussing that a lot of this intervention procedures or even your hero devices or endo AVFs or prosthetic grafts, they are all available, they can be utilized, no doubt about that, but finally in our country it is the cost. Prosthetic graft is going to cost you 1.5 lakh rupees just for the cost of the graft. Putting it and surgery is another part of it. So practically, if you ask me, we have discussed with nephrologists, we stop that, I mean, we close that fistula and do a new fistula. That's the best approach is as far as our patients and our country is concerned. Of course, you have a patient who is a paying patient, he's got insurance cover, then you can definitely try and salvage the fistula. You can go in for interventional procedures because they really do an excellent job and they can salvage the fistula. Only disadvantage in doing a new fistula is you are again waiting for 4 to 6 weeks for that fistula to mature. If they do an interventional procedure, that's the biggest advantage. If they can do it intervention, the balloon dilatation, stenosis is relieved, the fistula can be used immediately. But it doesn't end at that. Once you do an intervention with an interventional procedure, balloon dilatation, there are always chances of restenosis. So you have to keep a follow-up for these patients.
Thank you, sir. What is your experience?
Yeah, basically, if you have done a fistula and the fistula is functional and the patient has received dialysis for maybe a period of 6 months or 1 year and it stops, my observation is those patients again come back to you. They don't go to any other person. So as we discussed yesterday, that you do the distal fistula first, so you have a planning for the future. These patients, if the second fistula also works for a year or two, the third fistula also, they come to you. Basically, you are the person who is going to do all that. The option of AV graft or any other devices to be inserted is your decision. Convey to the patient. When you surrender that it's not possible, I can do it. So my advice is conserve the sides, do the distal most, and do a good job. The patients get a decent length of time under the fistula, and 3 or 4 fistula, if that patient survives that long, they come back and get it done by you only.
Thank you, sir. Sir, regarding the cardiac failure or the patients, so how often do you get patients who are having like cardiac comorbidities also, including this kidney failure? So what is the approach in those
It's not
patients?
very common, but they are generally evaluated by the nephrologist before they are sent to us for the ejection fraction component of...
Yes, sir. As you mentioned, the absolute contraindications that
less
have
than
to be...
20, don't try and do it. Of course, it's not a absolute contraindication, it's a relative contraindication. It depends on patient's condition also. And so if the EF is low, then you can get it evaluated by the cardiologist, and then you have a discussion with cardiologist and nephrologist.
So
but then you have to have an very close eye on the patient and watch the patient for any signs of failure.
Yes.
Yeah, the many patients are hypertensive. Some, will be having pressures in the range of 210, 220. And the patient comes to the OT table, once goes to the OT table, maybe that apprehension adds to it. And I have seen some patients developing dyspnea on table.
Yes.
And the situation falling. So the treatment at that time, before you organize everything, give one Lasix. Just give one Lasix, give oxygen, and don't do the surgery at that time, postpone the surgery. Because in my experience, I have had this occasion at least 6 or 7 times. One patient I was discussing yesterday, known to a hematologist senior colleague, his uncle, I saw the patient on table. I decided not to do the fistula because I was not comfortable seeing the patient. I sent the patient back to the ward. Within 10 minutes of reaching the ward, patient succumbed. So if coincidentally you are handling a patient like that, and many of these patients are frail patients, you have to be very, very careful in selecting the patients. When you feel uneasy with the patient, don't do the fistula, because doing a fistula, I am sure, is not going to cause the death of the patient. But the timing of the death, if it coincides with the timing of the surgery, the entire blame comes to the surgeon. You have no role to play, but the entire blame will come to you. So better, when you are operating on a patient who is looking too sick, don't do it. Why, a patient dying on a table, anything can happen depending on the relatives he has. Some are really, they can create huge problems. They can beat you, they can break the hospital. So don't take those chances if you are anticipating any problem with the patient. And all these patients are sick patients. And in the government hospital, especially the hospital where I work, there will be 10, 12 patients waiting. It's also bad because a normal patient cannot sit 2 hours outside, and you are making a CKD patient wait for 3 hours or 4 hours. That's absolutely not acceptable. So all these patients should be made to lie, and they should be comfortable before they go for surgery.
Thank you, sir. So at last, I want, because most of the audience, our delegates are young plastic surgeons who are entering into the field and want to operate AV fistula. And as you both were mentioning, sir, that all the plastic surgeons should know this art. So what one practical advice or tip and tricks you want to give to young surgeons so that we can use in our journey?
See, I think AV fistula is a boon for the plastic surgeons, especially young plastic surgeons. So you have seen the enormity of the problem and the magnitude of rise in AV fistula. So in a teaching institute, I think it gives the faculties the best opportunity to train the juniors, getting hands-on to micro instruments, microvascular exposure, and developing your expertise on microsurgery, because microsurgery forms a major chunk of our training and it's required in many other fields, so whatever you choose, related with brachial plexus surgery or implantation surgery or reconstructive surgery. So microsurgery plays a huge role in a plastic surgeon's journey. So in the initial phases, if you get an early hands-on on AB fistulae, which fine-tunes your skill, I think AB fistula is the best surgery for training the plastic surgeons. And the most important thing is you feel the thrill on table and you get thrilled. So the first thrill you see in AB fistula thrills you, and that thrill carries on. So I think AB fistula, all of you must put pressure on your faculties to have regular AB fistula in the department. That keeps your hands going, your training going. At the same time, other kind of work can be carried on. And this is a very not a long duration surgery. So once you get little familiar, it takes maximum 15-20 minutes, half an hour. So and done under local anesthesia, you are not going to request the anesthesiologist. You just have to find your own time and organize the OT table, that's all. So it's a big boon for the young plastic surgeons, I must tell you. Even though it's not good for the patient because there is so much of rise in the CKD, but that is a boon for the young microvascular surgeons. It gives you a direct training in microsurgery.
As a young plastic surgeon, from my point of view, both of sir has very long experience. They are very much senior. So what I believe, more you do, then you see your own complications, then you are going to learn. Only doing and seeing, feel the thrill, sadne bol diya, it gives a very good satisfaction to you immediately after doing. But on the long run, as sir told, all the complications, we should deal our own complications, then we are going to complete our full teaching or doing the AV fistulas. That is our goal should be. So we require and more to more, as sir told, we should keep on doing AV fistula, more AV fistula, see those patients again and again, and we should try to deal with those complications. Then only we become a complete AV fistula surgeon. So to become a complete AV fistula surgeon, we require an experience like sirs.
One important advice, see the international reported literature failure rates of AV fistula surgery is somewhere between 30 to 50%. So don't be afraid if your fistula fails. You're not the first one. So many of my fistulas have failed, and when I started venturing into this field, there was not many people who would have knowledge in plastic surgery about AV fistula. So I have learned the hard way, learned with my own failures. So even if the fistula fails, doesn't matter, everybody's fistula fail. So don't be afraid to do a fistula. Another important point what Vibhuti made is microsurgery. It's an integral part of our training. If you're working in a government institute or an institute where a lot of microsurgery work is going on, you will get hands-on at one point in time. But after you leave your institute and you go into private practice, you may not get microsurgery work immediately from day one. You might get an AV fistula work which is very easy to get access to and keep your hand in practice as far as microsurgery is concerned. Otherwise, you suppose after 1 month you've not done anything micro work, and after 1 month you get a free flap to be done, your confidence is obviously going to be low. You don't know, because 1 month you have not done any vascular anastomosis, so you're worried about. So this is a good thing to keep in touch with microsurgery. A lot of patients, the magnitude of problem is going to increase further and further, because we are supposed to be the diabetic capital of the world in 4 years' time.
2030.
So you can imagine by 2030.
2030,
so you can imagine the amount of patients that we are going to have. And one more point, we always, in our forums, we keep on complaining that our fraternity is being taken away by other specialities. I mean, our kind of surgeries, like we have very few people now are doing hypospadias. I don't see, if you see all our conferences, there is nothing, nobody is talking about hypospadias now. Cleft is also decreasing, maxillofacial work is also decreasing. So see, the change is going to be there. People, you cannot stop people from venturing into our domain. But then we can go one step ahead, enter into a domain which is, there is a huge patient load, and try and capture that domain. I think that should be our approach as young patients. Not only fistula, but like lymphatic surgery. Nobody is going into lymphatic surgery much. Not many people are going into brachial plexus now. And when I hear talks about, other specialties taking our work, I feel how many of us are doing, if you go to a hand conference today, how many plastic surgeons are there in a hand conference? Not even 15-20% are plastic surgeons, orthopedic surgeons. Even ENT surgeons, they want to come and learn from us. ENT surgeons are doing free flaps because they are willing to work. So you should be willing to go and you learn a lot of things from other specialties. Lot of things. It's not that, you should stick to, you should go with them, you should operate with them, you will learn from them. And then, as we said, we try and develop new skills, because you have to find new skills to survive. Otherwise, you won't survive. Change is going to be there. You can't stop other people from doing what they are doing. But then you can improvise yourself. I think that would be what I would advise.
I just want to add on this. See, yesterday you had Dr. Parak saying that he started and then he took off. And now most of the AB fistula in Pune is being done by the plastic surgeons. So this story is similar here in Odisha. In Cuttack, Dr. Giri was in the department. So all the fistula were done by urology and CTVS surgeons. Not a single was coming to plastic surgery. We started in 2007 or 8 doing fistula. So what he has already, Dr. Subha has already told about is you have to become a complete fistula surgeon. It's just doing a fistula, but managing the complications, avoiding the complications, and doing fistula better. Why we do fistula better and why fistula is now coming to the plastic surgeon? All the plastic surgeons are skilled microvascular surgeons. They do under loop or some kind of magnification, and they use fine suture materials. And their handling of the vessels is far superior to any other specialty. Therefore, the results delivered by the plastic surgeons are superior to any other surgeon. So any plastic surgeon who takes up this branch seriously is a serious contender or much ahead of any other specialty who is doing. So you are definitely going to do better than urology or cardiovascular surgeon when you take off AB fistula seriously. So I think it's a very good platform, and all of you have the skills and the orientations to excel. And this fistula has come to the field of plastic surgery in the last decade, and we should maintain this and it should not go off. And just like diabetic foot is on rampant increase now, the fistula rates are also on very high rise. So all of us will have very good potential to get cases, to do these cases.
So one question has come from many of the young surgeons that initially after passing, when they are getting cases, they are getting the cases and the limb is swelled. So what should they do? We know different procedures are there. We have already started. A lot of people yesterday has asked in WhatsApp that experts should tell if they are getting this edema hand in the first instances, what should they advise? Like we advise in different way. When they are single and they are getting this type of cases, how should they go?
Yeah, I think one very important thing that you have to finally develop a good rapport with the nephrologist, because he has to give you a patient which is well prepared for AV fistula surgery. And I think creating public awareness is also going to help. If you have an edema patient, I mean, it's obviously the patient is in overload. He needs to be dialyzed. The edema will settle down with limb elevation and dialysis couple of days. Sometimes, like when I went to Kolkata, there was a patient who was admitted. Nobody was willing to do his AV fistula because veins were very small. And he came, he was practically breathless. So I told him, now I'm going to Kolkata. So I told my nephrologist, you do dialysis for 3 days in a row. And when I come back on Monday, I will do the fistula. So that is how we did. So you have to have a good rapport with the nephrologist, because he is the person who is going to give you good patients. I mean, well prepared patients. And that is what is very, very important. Another point, as far as young people who are going to venture into this field, have a good rapport with the patient also. Because see, another point which we miss, that patient is on dialysis unit in dialysis unit for 3 hours, 4 hours. He has nothing to do. He's just watching a TV when a needle is pricked and his hand is in. He is going to do a lot of chatting with other fellows who are there are about 15, 20 fellows who are taking dialysis with him at the same time. So they talk to each other. That is what is my experience. They talk to each other. अरे किसने किया फिस्टुला? कितने साल हो गए? 3 साल हो गए. अरे मेरा तो 6 महीने में बंद पड़ गया. You know, that is how it takes. And they talk to each other and then they will generate patients for you. So eventually, even today, I get references, I get calls from hospitals, dialysis technicians. कि सर ऐसा ऐसा है, उसका फिस्टुला ये डिस्टल किया था, उसके बाद लेफ्ट में प्रॉक्सिमल भी किया था, वो भी बंद पड़ गया, अभी उसको मैं आपके पास भेज रहा हूँ. Because they know who does good fistulas. So we always know a staff or an anesthetist will tell you from the head end who is a better surgeon. So it's like that. They know who does good work. So they will also tell you. So always have a good relationship with patient, dialysis technicians. And as I told you yesterday, once you have done a fistula, if you know if you are working in one institute, then you can visit dialysis center once in a while to see your patients, and they will also feel nice कि अरे सर्जन आके देखे के तो गया मेरा fistula कैसा है. Because tomorrow that fistula fails, he is again going to come back to you if you have a good rapport with the patient and dialysis technicians. So that is what you should, because finally you have to build work for yourself. So that is the way you go ahead.
That means they have to choose the patient selection while doing first cases, initial level.
Yes, because you should not have mortality like he said in your first this thing, because otherwise they will feel that you are not doing a good job.
Yeah, yesterday, all the 8 cases, there was no edema whatsoever. All the veins were very well seen.
Yeah.
So this is the ideal thing. But what happens in normal government medical colleges, it doesn't happen. 50% or more of the patients have edema. And in spite of going for dialysis, they come back where the veins are not clinically visible. There your anatomical knowledge comes into play, but you have to be backed by your radiological ultrasonography or Doppler study to show that the veins are good caliber. Then only you can venture to go in. If there is a edema and you are not seeing the vein, don't explore the patient unless there is a radiological proof of a good vein and which vein to be done.
Thank you so much, sir. So with this, we come to end of our panel discussion. There was one question in the chat box, sir, regarding the lower limb fistula. People were curious about it and wanted to know that what is the feasibility, technique, and your tips.
Yeah, as I told you, look, if you have a complete understanding of the AV fistula surgery and good technique, you really need to go into lower limb for an AV fistula. It's not advisable because chances of trauma, chances of veins getting thrombosed in lower limb are much more as compared to upper limb. And see, patient has to undress on dialysis in dialysis unit if you are going to do a lower limb fistula in a thigh or put a graft or something. So it's not a very comfortable situation for the patient.
Yes.
So I would not advise to go in for. If you are good at you have the concepts clear about AV fistula surgeries, you don't need to go in for lower limb fistulas.
Yeah, if you have planned longitudinally, then by the time patient is required to do a fistula on the lower limb, I don't think patient will be there.
Sir, what about your take about venogram or venography, जो channel vein को detect करते हैं just before putting cannula or something? There is a one device
like infrared cameras or which
to detect the vein and after.
So using that by
But that, I think that IR camera is mainly used for lymphatic obstructions and lymphatic surgery. So maybe post-operatively, if patient has got edema, lymphatic leak or anything, then you can use that IR camera. But duplex ultrasound is very good. There is no question about it. And you should have a sonographist also who takes interest in doing, fistula patients, because most of them are overworked. They have a standard template of, reporting, and they will just take out a printout. It's stored in Word file. They just take a printout, just add a couple of sentences here and there and give the report. But as I showed you the report which my radiologist gives, I have told him, I have given him a table. I want all this information when the patient's fistula is to be done. So I can share that template on the group. Let me find that photo and I will share it on the group. So you can ask when you refer the patient to radiologist, You send the template. Okay, I want this all information when you do an Doppler for this patient.
Thank you so much, sir. Thank you.
Yeah.
Now
Thank you. All the best.
Now I would like all the delegates to please come on to the dais so that we all can have a good picture together. Yes, sir.
Tables are ready.
Yes, sir. Thank you. Thank you.
इसको स्ट्रेटन करना पड़ेगा ये भी so that it will lengthen. This is going to be the apex. So your cut has to be like this. And then you will join it to, then you take after cutting it like this, then you will see how it is reaching. And then you clear advantage only in that area and do an arterotomy and ask them to get a free number plate. ठीक है पहले से किया हुआ है ट्राई कंटिन्यूस अरे ब्रेक इसमें एक एक एक्स्ट्रा टेंशन देने के लिए अच्छा है कंटिन्यूस बहुत डबल इंडिविजुअल है ना ये सब अच्छा नहीं लाइक आई शो स्टार्टेड टू डिफरेंट स्टार्टेड दिस एंड कंटिन्यूस लेते जाओ आधा घंटे बंद करो उसको छोड़ दो स्टार्ट फ्रॉम द अदर साइड दैट इज हाउ यू गोइंग टू ट्राई एंड कैसे करोगे Suppose you start from here. It's okay, you can start from here. Switcher लेके आप ये first switcher का जो thread है वो is longer. So that you can pass it underneath and increase the vein 180 degrees to the posterior. That you do. Otherwise you पूरा twist कैसा करोगे? ये यहाँ पे एक्सटर्नल चलता है, इंटरनल चलता है, इंटरनल नहीं होता है. So ये जैसा आपने लंबा जोड़ करना है. ऐसा करना, see then you can see the posterior wall. No? So if you take one long suture at this end, one long suture at this end. कट नहीं रहेगा. एक ही चीज़ है.
This way you have isolated from the
You have to do a nice side लेके ही करना. ये दूसरा सीजर है क्या? सीजर है क्या दूसरा टॉपिक? Because that this if you have to go into side here. एक मेन को ऐसा रख के इधर पिन करो. Then you get perfect angulation. Then you can dissect and scissor has to cut. बस हाँ ठीक है चलेगा. काटने का तो चाहिए. नहीं वो माइक्रो सीजर कट नहीं करना. वो देखो अभी क्लीन करो इसका प्रॉपर नाइट्रेटमी. वो तो हुआ ही है एक्चुअली. वो नाइट्रेटमी whenever you want and then you have to decide. Otherwise you will not get the feel of doing pills. Two pills में नहीं होगा. असे पिन आणायला सांग ना त्यांना सगळ्यांना. एक्स्ट्रा आहे ना त्यांच्याकडे. हां one more pin. Put it here in traction. Then you will be able to do nice end to side. हाथ से करता हूँ. Right. You see the 70 is a good suture. You should know the tension, amount of tension you can have. थोड़ा प्रॉब्लम ये है कि इसको अगर ट्रैक्शन नहीं दोगे तो इट नॉट keep on हर एक के ऊपर एक 15 100 एक जगह पर पिन चाहिए. पिन आएगा तो पिन जैसे पूरा पिन लगा टेंशन मिलेगा ना तो देन यू विल बी एबल टू डू दिस प्रॉब्लम. अच्छा इसीलिए अच्छा हाँ लास्ट ईयर यार ऐसे ऊपर you are joining now plastic surgery. Not joined yet. अभी बड़ोड़ा
same as this year.
तो अभी लास्ट
हाँ वो very
अच्छा repetition
or in the country. See, you can you try not at 9 o'clock. यहाँ से चालू किया पोस्टर वहाँ लेके यहाँ एंड हो गया वहाँ पे नॉट ट्राई कर दो तो नॉट का डबल स्विचर वैसे रखो एंट्री उसी वॉल से कर सकते हो इवन इफ इट इज नॉट डबल एंट्री re-enter from the artery, from the posterior one. You have to re-enter the artery from the posterior one and then take the vein and then go.
Coming in my way, there was so then I put it out here and now I'm just taking the same needle and doing that.
You can do the same thing with a single needle also.
No, so this is all of us. This is all of us, yes.
That's it.
This is going to reach here like this at an angulation of 30 degrees. So I'm going to make a cut in the artery. On the side where the vein is coming. Can I have some light here? हाँ है लगा है ना माइक लगा है So can you see the arteriotomy now? दिखता है क्या? Yeah. Okay. और zoom होगा क्या?
हाँ सर जाएगा
करो zoom करो हाँ हाँ बस बस बढ़िया
लाइट दो आउट लाइट दो पूरा सेट दो कम कष्ट कर
Yes. 70 6070 क्या है 60 नहीं 60 लेंगे it vessel is thicker ना So abhi lot of people ask me how you once you tie a knot at 3 o'clock how you re-enter inside so we just pause this clearly. So this is the artery I'm entering from outside in okay. And for the vein, I'm going inside out now. So once you have done that, you have two threads. This is a long thread. Can you zoom out? Zoom out, please. Yeah, best. So now I have two needles in my hand and I'm going to tie knots with hand. Okay. Now once you do that, one needle is in my right hand, one needle is in left. So the right hand needle, I just keep it like this. You can put some pressure on that. Okay, okay, fine. Then with one needle, this is your first stitch. Now you have to re-enter. Now you cannot re-enter from here. Okay, otherwise your thread will come over the first knot. If the thread comes over the first knot, you are actually compressing the vein there. So what you have to do, go posteriorly. And from posterior side, you will enter the artery again. Did you get this? Did you see? Okay. So now I am again inside. I am going inside out on the vein side. At the same time going outside in on the artery side. So once you do that first stitch, then it's very easy because then it's a running continuous suture on your forehand. If you take the first stitch wrong, then every time you have to go reverse hand. Like you have in tennis, backhand and forehand. So this is going to be forehand. If you do the ulta way, then you will have to do backhand every time. You should be well versed with both the techniques. So now again I am inside, I have to go inside out on the vein side and outside in on the artery side. I generally don't lock. Oh. Zoom. Are you able to see it now? Okay. See, to begin with, this may not be possible for you to do two bites both on artery and vein side in one go. So you will have to go slow by taking bite from artery wall, then take out the needle, take a bite from vein wall. So I'll show you that also. So now I'm vein inside out. And I have to come from outside in the artery now. So now we've completed. I'll just open the anterior wall and show you the anastomosis posterior. Retract that side, please. Can you see now it clearly? Wait, give me a gauze if you have just two mops. नहीं है ना कुछ पेपर है क्या? So that clarity आ जाएगा उधर. दिख रहा है? Now I am outside and I have to tie a knot. Okay? I am outside on the vein side. Now I have to take a corner stitch. The leakage is majority of the times from the corner. If you miss the corner stitch, okay, so you have to go at the exact corner. So I'm going from here. I'm inside now. Okay. What I did was I just pulled the thread. So you can keep it little loose outside here so that you can tie a knot with this once I come out. So I'm inside on the artery side. I'm coming out on the vein side now. So everything is out now. So we can try a knot here. So the knot is outside. Okay, I'm not taking 2 minutes. Now after this, somebody asked me how you continue. So don't use this needle now. This needle is kept aside. And then you use the other end needle. You are already outside on the other end needle, and then you again start with outside in, inside out. Then you just go continuous running sutures. Oops. So once you reach here, you can directly tie knot with the other suture. So you take the other suture in hand and then you can cut. So now I will just see the posterior wall now. Okay, zoom. Okay. So this was end to side. Now we'll go for side to side. Yeah. Yes. It's not required. Don't lock. Not required. Because even if you lock one suture na, the whole configuration changes. Wall to wall approximation completely changes. One knot will go cross. And there are good chances that if that is not sealed properly, you will get a leakage. If at all you have to lock, you can lock the first stitch, not in between. Don't lock in between. Lock the first stitch and then go continuous posterior wall and then continuous anterior wall. So let's see the ऐसा करते हैं थोड़ा ना टेंशन में चाहिए थोड़ा मेरे को. वेट वेट. So we'll do now side to side. So let us say we are going to do it here. सेट दूसरा है क्या? ठीक है, नहीं आर्टरी से. So this is an arteriotomy here. नहीं गया कि नहीं? नहीं गया क्या? अरे?
This person level is very thick.
Okay. Yeah. ठीक है. छोड़ो. So similarly we cut it on this side. Now I'll open another 60. 60.
और एक 60 दीजिए.
अटकेगा नहीं. इधर इधर पीछे था ये पेपर आ गया. So starting from outside in. Okay, hold this.
अभी zoom in करो.
So now you have to go behind here. See, I'm going in between the. I just saw somebody, he came from here and he took the posterior wall like this. Then you are crossing your own stitch. So you have to go from underneath and then come out inside the artery. Don't go over it. क्या हो गया? नॉट बैठ गए? नॉट कैसे हो गए? उसको खोलना पड़ेगा नॉट को. So now I'm taking only one wall because that's going to be our last stitch. So somebody asked me, if you have one single needle, how can you do? Let us forget that you have a needle at other end. The same needle you can continue anteriorly also. So same thing can be done. Suppose you don't get a double-ended needle, in which case, at this corner you keep a long thread so that when you start from the other end and you reach there, there is something there to tie. I'll do that way now. I'll ignore that there is a needle at the other end. Yes? नहीं, पहला नॉट तो लेना पड़ता है ना. हाँ, कॉर्नर स्टिच का. सो दैट इज व्हाट, व्हेन यू टेक कॉर्नर, सपोज दूसरा नीडल है नहीं, कॉर्नर स्टिच का नॉट अब लोगे तो वो थ्रेड थोड़ा लॉन्ग रखना पड़ेगा दूसरा. Yes, I got a question. See, you go from outside in, you come from inside out. Then you take a knot. That same needle you are going to continue for the posterior wall. वो knot लेने के बाद एकदम short मत cut करो. वो length थोड़ा रखो thread का. Because anteriorly जब आप आओगे तो उसके साथ knot करना पड़ेगा ना. Did you get it or no? नहीं समझे तो बोलो, मैं दिखाता हूँ करके.
She's asking about second one.
So you took a knot there. Is that not mandatory? Or should we just continue?
No, it is mandatory. It is mandatory. It is mandatory. Because the problem is वो तो constriction हो जाएगा एक, and secondly, suppose like yesterday while I was tying a knot, एक thread टूट गया, हाँ, ऐसा किधर भी एक thread टूट जाता है, पूरा anastomosis खुल जाएगा. It's a high pressure system. So once you release the clamps, the pressure itself will open up all your continuous sutures. Posterior wall करके break किया ना, the other advantage is immediate post-op period you find a thrombus, soft thrombus. You just need to open the anterior wall. You don't need to open the whole anastomosis. If the whole anastomosis is continuous suture, once you cut one suture somewhere, everything is going to open up. Sometimes if there is no assistant, you can follow your own thread. Like this, you pull it up. And suppose you get a leak post-operatively after releasing the clamps. If the leak is minor, you can better not to put a clamp and take a stitch when it's leaking. It's easier. Unless the leak is so big that the field is getting completely bloody and you can't see anything, then only you apply a clamp. So you just check that not taken the posterior wall anywhere. So then you can tie a knot now. So we'll try and show the opposite side also.
ये फोकस कीजिए
Okay. Okay. So you can go back and try. I just wanted to show once so that you get an idea actually how it is done.
किसका घर ही है? 90 हो दे रहा हूँ और क्या करूँ? क्या? खत्म हो गया था। कौन सा दे रहा है? 90। अरे ये तो काटिंग स्पेचुलेटेड माइक्रो पॉइंट है। अरे भाई वो तो देखता कट थ्रू हो जाएगा। राउंड बॉडी वाला तो देखता हूँ। तापरे धीरे धीरे कौन होला आउ गवर्नमेंट रे एवरेज प्राइवेट बिका नहीं लिया
वाड़े एड़िया राउंडिंग कर दीजिए इतनी गोली और पानी भी तो लगोंडे सुस्त लग रहा है हाँ
Time watching Sir do it again today in front of us, demonstrating it over the porcine vessels, and following that, I hope all of you all had a good experience in practicing it. Once again, I'd like to thank sir. We really had a very, very enriching experience last 2 days, and I'm sure everybody has taken back few things which they would definitely be trying to inculcate in what they were already doing. So we'll just start with announce the quiz prizes. Giri sir will announce the prizes, and I would request sir to please felicitate them.
I will request also the quiz master. Tie both Dr. K. Srinath Reddy, K. Sriharsha Reddy, sorry, and Utsav Gupta and Utsav.
Yes, sir. That we will be telling them. So we have arranged some. Once we'll announce all the prizes, we'll announce it. Okay, please.
Second is Dr. Kriti Jain. First is M. Sivarama Krishna.
So it was a very. There were top 10 people, and everybody's marks were very close, like almost a half and 1 mark difference. But I mean, we were very happy that most of the questions which we thought that people will answer, they've answered, and some of them which we knew that would be difficult. So they were uniformly difficult, which is okay. So thank you once again for the participation. And so now I'd like to. What sir has planned for them, that all the winners will be getting micro instruments. So we have planned some parts of the micro instrument that we will be sharing with them. Obviously the first prize will get some more, the second prize slightly less, and the third prize slightly less. So it's not the whole kit, but and names will be engraved. We'll give you the person you need to speak to, and they'll get it for you. So it will just be like a small addition and a takeaway gift for those who won the prize. So yeah, thank you very much. So now sir, we will be announcing the delegates' names one by one, and sir will be giving the participating certificates to all. Dr. Akriti Komal, Dr. Balaprasad J, Dr. Bhanu Prakash Dash, Dr. Rahul Saini, Dr. K. Sriharsha Reddy, Dr. Pragada Sushmita, Dr. Svetashri Sarangi, she not here? All right, okay. Dr. Devalina Goswami. Dr. Shubhashish Roy. Dr. Chandan Das. Dr. Durga Prasad Panda. Dr. Apurva Kumar Naik. Dr. M. Shivaramakrishna. Dr. Kalai Selvan. Dr. Kaushik Dev. Dr. Satyabrata Rautre. Dr. Lipsha Swen. Dr. P. Bhavani Lia. Dr. Neha Sharma. Dr. Anurag Salvan. Are everyone who had registered from outside Aiims Bhubaneswar, have we covered? Anybody missing? Your name. What's your name, ma'am? Okay. We'll just get it printed and get back to you. Sorry. No, we'll get it, sir. Anybody else? You're Dr. Sonam Vadwani, right? Yeah, very sorry, we'll get it for you. So now, okay. No, it's okay. No, we'll just write it and give it to you. Photo. Okay, okay. Dr. Surya Yashasvi. Dr. Vidush Kumar. Dr. Utsav Gupta. Dr. Anisha Ganguly. Dr. Sonam Vadwani. Dr. Amrish Ramaswamy. Dr. Madan Mohan Reddy. Kirti Reddy. Dr. Kriti Jain. Dr. Dipanjali Shetty. Kirti ji. Dr. Kirti and Dr. Vidush have worked very hard. Everybody has worked, all our entire resident team has worked. But especially I'd like to acknowledge the work that has been done by both Dr. Kirti and Dr. Vidush. Dr. Mausam Maiti. Dr. Ashutosh Adhikari. Dr. Nikhil Malela. Dr. NCT. Dr. Ajay Dirvela. Yes. Okay. Yes. Okay. Thank you so much. I'd like to give first to Giri sir and then Parag sir to sign off the event and some words of motivation for the young surgeons here.
Thank you, Parag sir, for giving 3 days of time to come here and make this event. Whatever it may be, you must be getting something. And to start with, we have started last 2 months or 3 months back to start this event, and we started it. And sir, during his itinerary also, sir told that he is coming on Thursday, but unfortunately flight has probably and then some delayed. We are also a little bit of what to do, what not to do. But anyway, sir has come in the next morning. So sorry for all the inconvenience, sir. So by the way, next I will go to the teams. I will go from below because there are some people who are behind the scenes, like our administrative team, like this Amal Babu, and come to the front. And Sandeep and Chinmay, Devi, because lot of things are there which remain behind, and they work for last 2-3 days. Come here. And Devi and anybody else? And Hare Krishna and Nirmal, all of them are doing lot of things, which is Badal, and they all are doing very small things which is required to make these things happen. Yes, so please give a big round of applause for them. Next we will go to our resident team, because without their efforts in all these things, to collect the patients, to have all the logistics required for all the patients, 8 patients out of 10 patients we have selected, another 2 patients we are not able to do it. So 10 patients, their profile and everything to coordinate and to make them available for the OT. So thanks to all the resident team, they have done a good job. And I will especially thanks to Kirti and Vidus. They are doing all the logistics for last I think 15 days. They are doing irrespective of their duties. They are doing their duties, and the extra time they are doing all those things. Then we will go for our faculties. All faculties are involved for last 3-4 days, and Ahana and Sikha, they are mostly coordinating all these academics and all these things. So big round of applause for Ahana and Sikha. Although all the faculties are involved in every aspects. Next, I will go to our administratives. They have given the permission for 2 days to utilize this mini auditorium, and also we have already acknowledged the OT persons yesterday in the OT complexes, because OT technicians, nursing officers, everybody's coordination is required. Then I will come to this, our audio-visual team, Prasanna and photo, because with that there and this technical team, stars, because we have integrated OTs, so stars people, they usually help in integration so that we are able to see whatever activities we have done in the OTs yesterday. And then we will go to these, all these delegates, those who have come from a long distance, and thanks to all of you. And we have tried our best to make you convenience if anything has from our side. Sorry for that one. And hope we are going to do a lot of workshops in the futures, and hope it will be going to helpful to you. And also we have a online, I know there are some problem in the online, but on online also 50 to 60 people are there. Of course some glitches were there yesterday during Zoom meetings, but it happens in all the events. And if I have left anyone, of course some sponsors are there, thanks to them. Without them this event would not have been happened. And if anything has left out from our side, sorry for that one, if anything has happened. And I would hand over to Parag sir to say a few words.
Yeah, thank you, Giri. I think I am overwhelmed with the hospitality and the arrangements made by Giri and his team. And he's the most, I will say, enthusiastic head of the department in the country. He organizes workshops every, maybe alternate month. Yeah. No, it's really good for the residents who are working here. So he's become a master in organizing workshops. So first congratulations to him and his entire team, Kirti, Vidush, Shikha, Ayusha, because Kirti was sending me PDF files every time, sir, this is the history, iska kya karna hai, brachio ke pehले karna hai, radio ke pehले karna hai. After getting all 8 PDFs, at the end of 8 PDF, I got confused, iska artery ka diameter kitna hai, kya hai. So, but I tried to reply to best of my ability, and yesterday also, I mean day before yesterday, I missed my flight, so there was a problem, but it got sorted out. So thank you for the entire department of plastic surgery Aiims for inviting me here, and I would specially like to thank entire OT staff, because yesterday's arrangements in OT were really fabulous. See, though you have worked and you have done many surgeries, when you go to a new place and you are going to demonstrate something to people, that anxiety is always there. Your new place, I don't know what kind of arrangements will be there, what kind of instruments. So I got my 2 instrument set autoclave from Pune here, along with the loops. But I didn't need to open that, because everything was, I don't know how they managed for 8 cases. Either they are rich and they have so many micro instruments, or they were autoclaving in between the cases. So thanks to, so special thanks to residents, how they manage. So it felt like I was operating in my own theatre, so that was the comfort level that I had yesterday operating in operation theatres. So thank you for that, and obviously thanks to all the delegates. I am overwhelmed after seeing, I was asking where are you from, and people are saying Chennai, Kolkata, Jammu, and I am really Amritsar, and I am really overwhelmed that people are travelling all the way to learn Navy Fistula. I am extremely happy, and I am willing to teach more and more. So I hope everybody has filled the feedback forms, because anything extra that can be added or anything extra that you want, we can do it next time. Probably next year, early January or February, we'll do a workshop in Pune, that is a biennial workshop that we normally do. So you're welcome to come there also. So anything lacunae from my side, please let me know. I will request Giri sir, you can keep this WhatsApp group open if possible, so that any questions anytime you have, you can always contact me. Even if you call me intraoperatively, sir, I say a problem, there is no problem. I will answer your queries. So thank you again for inviting me here, and I think we can declare that this workshop is closed. Thank you.